Moving on to the next session, which is a panel discussion. I would like to invite on stage Dr. Ashita Srivastav, who is a fetal medicine specialist in Patna. And I don't think ma'am needs any introduction. I would request Dr. Ashita to please invite Dr. Sita ma'am. Ma'am, please.
I request Dr. Sita Ramamurthy Pal ma'am to come and moderate the session.
So we are moderating together the session. So as we invite the panelists, may I invite the first panelist?
The first panelist,
We've all heard them. They're all eminent fetal medicine, budding fetal medicine specialists and very good. And we of course have our expert with us, Dr. Krishna Gopal. Where is he?
Sir, please come.
Dr. Krishna Gopal, sir, we need your expertise here. So welcome. And of course, he doesn't need any introduction.
Dr. Pooja.
Next is Dr. Pooja Kumari, our own very own, who's trained with us in Kolkata and right now practicing fetal medicine here. Now, Dr. Bhavya Sareen. Welcome, Bhavya. Where are you? She was here only. We've seen their excellent
Dr.
images
Aishwarya.
and what they do. Dr. Aishwarya, where you come, please.
Dr.
Dr. Mrinalini. They had presented papers in the morning, so welcome again. So what we're going to discuss is some very common findings that we see, some markers, some minor markers as we call it, or some major markers which are actually congenital abnormalities, very common scenarios we'll see. So we'll start off with the first one. So Mrs. CK, she's a 25-year-old primary paras. She's a low risk for aneuploidy in her first trimester scan, and she's come for her TIFA scan, which is a level 2 scan at 21 weeks. So Bhavya, can you just describe the image? We'll just run the video. No, this is just a still image, yes.
Ma'am, this is an oblique view of the lip showing a bilateral cleft lip. The nose is seen on the right side, the nasal tip, then the upper lip, which has two clefts, and the lower lip and chin is seen.
Yeah. So you can definitely see that there is a gross gap in the area of the lip area. So if we have to go ahead, what do you think is this is a very, sometimes it can be missed, but we have to evaluate every organ as we have in our guidelines as to how to evaluate them systematically. So when it comes to face, what are the planes that you would normally tend to tell them to evaluate?
Ma'am, we have the axial planes, we have the sagittal planes, and we have the other oblique planes also. In this case of cleft lip, ma'am, we would like to see the axial plane so that we can evaluate both the lip and the palate, because the bony cleft will not be seen in this clip in the first image that was shown. Axial images can be, ma'am, either lateral or ventral approach. Ventral approaches are better if we want to rule out bilateral clefts.
This is a video.
Midline, in this case especially, mid-sagittal section will not be very helpful because always the philtrum, the protrusion is not seen, so it may be missed, but some of the parasagittal views may be helpful.
So,
and we would also see the
can you describe this further image?
Yes. The coronal view of the palate also, the oblique view of the palate also we will see. It will show the connection of the mouth and the nose.
Right. So basically when you are targeting the image as in terms of the face, the coronal view is the nose chin view that we say is the first thing that we see, where we see the nostrils, the upper lip and the lower lip. And any defect in that, it starts off with your suspicion whether there is a defect in the lip, and then we further evaluate to see whether there is association of the palate or any other secondary palate, right? So as you said, this is the aerial view of the lip, where we see if there's any gap in the alveolar ridge and if there's any communication, which we can clearly see there is unilateral lip, one cleft which is actually communicating. There is an alveolar cleft there, and that is the cleft palate here. And here in the sagittal view, what are you seeing? What should be ideally seen?
This is the philtrum. There is some extra tissue which is there at the pre-maxillary area.
That is the premaxillary protrusion that we see typically in terms of bilateral cleft lip and palate. And the maxillary line, as we say, is incomplete.
Incomplete, yeah? Yes, ma'am.
Yeah. Dr. Krishna Gopal, you wanted to add something here?
Axial is
The
important, and nose
Nose chin view.
chin is the better for this. But what is needed that you should see the cleft and the both the lip and the palate, and in which direction it is going, what is the extent, so that it is not just what you put in your words. It is that how much this report is useful for the pediatric surgeon
Surgical
itself.
point of
So you have to make your reports because this is the way you are communicating with the treating clinician. So you have to make it in most descriptive way and with the pictorial representation as well.
Absolutely. Would you recommend a 3D evaluation in every imaging that you sort of, especially for lips?
Of course, it is not useful to see for the extent, but also it is very useful for the counseling of the parents.
Yeah. So here, if you can see a communication between the, clearly the communication between the nasal cavity and the oral cavity. But yes, 3D imaging is definitely there to, explain to the couple and explain to them what the prognosis could be. And every anomaly is seen that is not necessary done for termination. It is done to see whether it is correctable and how it is. So that is the exact picture we need to give it to the couple. So Bhavya, Aishwarya, can you just elaborate on what are the types of cleft lip and
Now,
what
the
is more
types of-
common?
The types of cleft lip are unilateral cleft lip, where there will be only a defect in the lip. Then is unilateral cleft lip and palate. Then is bilateral cleft lip and palate. Isolated cleft palate can also be there, which is very tedious to find on ultrasound. Especially axial view will help in that. And median clefts are also there, and especially if median clefts are there, we need to look for holoprosencephaly, the facial profile,
As we saw in the
and
morning.
proboscis, cyclopia, and holoprosencephaly, and linked to trisomies. Yes, ma'am. And the most common is, ma'am, unilateral cleft lip and palate. And yeah.
So when you see such a finding in your second trimester scan, the first thing you've noticed there's a bilateral. What is your approach? What will be your Pooja? Pooja, you can take that, yeah.
So in this case, the face needs detailed evaluation, and it is already done by them. So detailed ultrasound examination of whole of the fetus is needed to rule out all other associated anomalies.
So any anomaly, the bottom line is always any anomaly, small or major, you have to have, even though you might have done a proper TIFA scan or you finished your scan, if you find something, you go back and evaluate from head to toe whether you've missed anything, do a detailed, especially because cleft lip, facial are always abnormalities associated with craniofacial abnormalities, the sagittal view, nasal problems, and those, flattened bridge of the nose and everything. So you have to evaluate, have a detailed evaluation. And yes, there are associations because as we said, if it's a median cleft, there is absence of the philtrum, it will be a median cleft palate which may be associated with cranial abnormalities like holoprosencephaly, which has poor prognosis, especially with trisomy 18 and 13, and then the associated anomalies with cleft lip is only around 13%. So you have to make sure whether the lip is associated with a cleft palate also, and that is why we need extended views. So typically if you have a nose chin view, then we have an aerial view as we saw where there is a defect in the alveolar ridge, and you can have the retronasal triangle if the triangle is not completed, but that shows there is a possibility of the gap in the secondary palate. Yeah. So we go on to the next, Dr. Pooja. Any important history you will go back, because when you tend to scan, we've already said that her first trimester screening was normal, but as you're seeing things, you tend to think of the possible causes. So what else you want to evaluate?
We need to know the etiology of, because it occurs due to the interaction between the genetic factor and the environmental factor. The environmental factors include alcohol, smoking, vitamin B6, 12 deficiency, folic acid deficiency, any chemical exposure, any teratogenic drugs exposure,
She's
like
on,
anti-epileptic drugs and all.
Warfarin.
And also family history.
Diabetes is also very important to rule out, because that's something we don't know. We know as we scanning, we have to ask. And then only when we ask leading questions, they tend to say, yeah, I'm
get the
diabetic
answers
on
from
insulin. Whether it is well controlled or not, those sort of issues have to be concerned. So, Dr. Gopal, back to you again. We have seen here, this lady has an isolated bilateral cleft with unilateral extension to the palate. No other abnormalities. First trimester screen is low risk. And, so how will your counseling be in terms of, and she has no other positive risk factors, as we said, no agents she's taken, no alcohol, diabetic, she's not diabetic. So how will your counseling be? Invasive testing, yes, no? What test on invasive testing? It's a lot of things.
So the message I want to pass on is that whenever you see one that defect, congenital abnormality, so you should not stop there. You should go back, search for the systems again to rule out the chances of the chromosomal as well as non-chromosomal abnormalities, because cleft lip, cleft palate is associated with more than 300 syndromes. Secondly, whatever the knowledge we have so far, medicine is an ever-evolving science. So though the chances of having isolated median cleft lip with the chromosomal abnormality is less, but it is seen. It is not that we have not seen even in the isolated cleft lip also. Yes, the median it is, the chances of having aneuploidies are much more, like the trisomy 13, followed by 18, followed by 21. But given all this counseling, you must offer invasive testing also to them, because this is a choice that the patient has to make, being informed about all this risk factor and the background and the information we have so far. So I would like to offer her invasive testing, giving all this background also. I will like to go for CMA, that is microarray 750K, as well as the karyotyping with the preservation of the DNA for the future testing if needed.
Absolutely. Thank you so much for that. So nothing is 0 or 100% in science. We know that. Though we've said that there is no associated anomalies, it is unless proved otherwise. In the sense, we have not investigated to say it is isolated. So here it is structurally what we can see, that there is an isolated cleft lip with an extension on one side to palate. There can be, you have to think beyond the chromosomal problems. There could be genetic syndromes. So though her first trimester risk was low, which was only for the common trisomies. We don't know about the other genetic syndromes which could be associated. So yes, please counsel them. Please recommend an invasive testing. The choice is the couple, and document whatever you're doing so that tomorrow they didn't say that we didn't know about it. Yeah. So at this stage, would you like to, Mrinalini, would you like to involve anybody else? So we've done our amniocentesis and the CMA is normal for 750K. Do you want to involve anybody else? And the couple have decided to continue with the pregnancy, because we have reassured them as of now that yes, more or less everything looks okay. So do you want to involve any other specialty here at this point in time?
Yes, ma'am. I will counsel the patient about the prognosis, that the survival and prognosis is very good for these children. But yes, there are certain long-term and short-term difficulties in these children. Like short-term difficulties, like they have feeding difficulties, breathing difficulties. So they must take a counseling from a pediatrician or pediatric surgeon. And for late or delayed onset, there may be problems like hearing difficulties, speech difficulties. Cosmesis is of course a problem. So they will have to go to pediatric surgeon, and surgery mostly is recommended at 3 to 5 months for cleft lip, and for cleft palate they recommend surgery at 11 to 12 months of age.
So it depends. So you involve a pediatric surgeon at this point, have a multidisciplinary approach,
Yeah, of course.
take them into your consultation, tell them, show them with pictures, and it's a correctable anomaly, so give them positive pictures of those who have been corrected and leading normal lives. So everything is not dark here. We are progressing, and there is so many people who are doing very good work in correction, and they all have, yes, the initial issues are there, but if they are counseled well, they take it in a very positive way. So all counseling has to be. So one more, Dr. Gopal, back to you again, Dr. Krishna, that sometimes there is falsely reported. So what do you think are the pitfalls in diagnosing cleft palate, clips especially?
So patience is the word. You just wait for the baby to open the mouth, swallow the fluid.
Yeah.
So if it is even a very tiny cleft, that is you are about to miss, if you have made this protocol to have this patience and let the fetus open the mouth and swallow the fluid, you will see those
Very clearly.
those clefts also. Those are
So
not there.
never be in a hurry to, that is again important message, never be in a hurry to finish your scan. You should have the lip and the palate actually surrounded by good amniotic fluid around it. Sometimes you see the face is, sort of stuck to the placenta or stuck to the uterine wall, and then you tend to think that is normal. No, just wait for the baby to move. You might have to call her again after some time. And, especially if the baby is in the sagittal view of the fetus, it is very important to get a proper view. You document the entire maxillary line with the superimposed vomer as well to see there is no defect in the secondary palate. And then as he said, if there is fluid in the oral cavity, that is magic. It will clearly delineate all the upper lips and the lower lips and the features, especially if in the aerial view, if you can see the defect there or not. Yeah. So, and the one more thing we also said here, especially there was a cord around the lip, so around the face. So you have to put color and make sure that is not giving you a false positive diagnosis. So yes, incidence is 1 in 700, but if it is cleft lip and palate, it can be complex and multifactorial. You have to rule out chromosomal abnormalities, especially 13 and 18, but think beyond aneuploidies, think of genetic syndromes, because a lot of them, if they have associated midfacial hyperplasia or a binder species, can be associated with Pierre Robins or Treacher Collins, and that can be, has to be counseled accordingly. And especially facial clefts, as isolated facial clefts are very difficult to diagnose. Remember, examining facial cleft palate is not part of the routine standard here. We always say look for cleft lips. That is what the guidelines say. But if you see a cleft lip, it is, you cannot go without making sure that there is a cleft palate or not. So because isolated cleft palates are very difficult to diagnose by its own. Yeah, thank you. So prognosis depends on the type of the presence of single, bilateral and type of associated anomalies. And we've said that isolated is good prognosis, and recurrence for every anomaly we see the patient is only concerned, is baar ho gaya, agli baar kya hoga. So you have to say it depends on, that is why we need to find the cause and not just terminate it at the drop of a hat and then forget about it until the next pregnancy. We come back, call them, reiterate, store the DNA, that takes only 2,000 rupees even if they have to terminate. And then depending on the risk, if there is one sibling, it is 5%, and if 2 siblings are affected, it is 10%. So we go on to our next case, which Ashita will take us through. If there are any questions in the panel, please ask the experts, or clear your doubts as we go along each case, because these are some common scenarios that we see in our day-to-day practice, and how to counsel them, what is the significance of counseling is important. Come.
Now, second case is Mrs. SS, 25-year-old, come for regular ANC at 20 weeks. At level 2 scan, this was the finding. Dr. Mrinalini, please describe the image.
Thank you.
This is the transventricular section of fetal head. We can see clearly in anterior complex, CSP is visible as a gap in the interhemispheric fissure. And beyond the CSP, we can see anterior horn of the lateral ventricle. Posteriorly, we can see the posterior horn of lateral ventricle and atrium. We have measured ventriculomegaly by placing the calipers from inner to inner margin at the level of parieto-occipital sulcus. The image should be magnified, and the interhemispheric fissure should be horizontal to the screen.
So measurement is 1.11.
Then it comes in mild ventriculomegaly.
So Dr. Mrinalini, can you describe what is the correct plane for measuring ventricles? Half of that you have already described. So what important salient points we should keep in mind when we measure ventricles, near ventricles, far ventricles?
For far ventricles, we should keep the plane, the section should be transventricular, yes. And the placement of calipers should be at the level of parieto-occipital sulcus, yes. From inner to inner margin for, yes. Far ventricles. Yes. For near ventricles, because of the reverberation artifacts, we cannot see in the same plane, but we will have to go slightly posterior towards the rhamnoid suture and give a slight tilt to the probe so that we can see the near ventricle. And subjective assessment is sufficient, but if it is looking seemingly, it is looking more, then again at the same level, parieto-occipital sulcus, we will measure the same.
So very nice. It is always better to measure anything. So, Dr. Aishwarya, what is cutoff of ventriculomegaly, and is it the same across the gestational age or different from second trimester to third trimester?
Ma'am, it is same in the second and the third trimester, that is 10 mm.
It is 3 to 4 standard deviation away from the
Away
mean.
from the
Thank you. So,
And you have to
Doctor,
make sure you measure calipers
Calipers,
of
Calipers,
correct
it should be inner
planes,
to inner level
yes.
at the level of atria,
what is
parieto, occipital
grading
sulcus.
of ventriculomegaly, Dr. Aishwarya?
Yeah, it is more than 10 mm, that is 10.1 to 12 mm is considered as mild,
Yes.
12.1 to 15 is moderate, and more than 15 mm is a severe ventriculomegaly. It is the mild ventriculomegaly which should be,
Very
which should
nice.
trigger us.
So, Dr. Pooja, what is asymmetrical ventriculomegaly?
When the difference between the measurement is more than equal to 2 millimeter of the lateral ventricle.
And when there is an unilateral ventriculomegaly?
Unilateral.
So it's always important to measure the
the-
near ventricle as well as a routine, so that it becomes a practice that when you have a ventriculomegaly, you have to see the
And what is importance of this? Because bilateral ventriculomegaly is shown in various literature that it is more associated with other brain abnormality in comparison to unilateral ventriculomegaly. So, Dr. Pooja, as a fetal medicine consultant, many of times you have come across that patient come with a ventricular measurement 8 to 10 and it is written as borderline ventriculomegaly. So, what is actual definition of this borderline ventriculomegaly?
When the atrial measurement is between 10 to 12 millimeter,
Very good.
it is
And
borderline.
do you really think that it is safe to use this term?
No, it's not correct to use.
Yes, because many
Actually,
of the
it is
cases,
creating confusion.
Dr.
To-
Krishna, you want to add
add
to this, because
something
we, a lot of
definitely.
times second referrals,
Yes, sir.
second opinion comes with borderline.
Borderline
Actually,
ventriculomegaly.
see, it is about the millimeter, and what the tricky situation is that if you are in mood to make it normal, you just put at 10 to 9.6 or 8.9 or something, or if you are in mood to term it as an abnormal, you just put it 10.2 to 10.3. So basically it is either it is there or it is not there. It is not. You may call it prominent, but it is not ventriculomegaly until it is more than 10 millimeter with the given standard guidelines for the measurement.
Absolutely. So there is a lot of
observable
inter-observer
variation
variation
also.
The same person, in the beginning of the scan you measure, and at the end of the scan you yourself will see that there is a difference in whichever. So always, yes, ma'am.
Just wanted to ask if you have great ventriculomegaly, can it lead to hydrocephalus? Any correlation with hydrocephalus?
Absolutely.
Yes,
So
ma'am. Yes,
we are
there
coming
is.
to that. Yeah.
Yes, ma'am. We will come.
There's measurement, there will be some measurement
Ma'am,
leading
we
to
will come-
we are coming
hydrocephalus.
to that.
So you have given mild, moderate, and severe, and then what about
We are
hydrocephalus?
coming to that.
Thank you so much.
Dr. Bhavya, what should be your approach in the ultrasound assessment of the cases with mild ventriculomegaly? You are doing your scan. As soon as you put your probe and you detect that there is a mild ventriculomegaly, what other things will you like to see in your ultrasound?
Except the TIFA scan that is done for the fetus, I will do a detailed neurosonogram, which will include the detailed assessment in all the three detailed planes, the axial, the coronal, and the sagittal planes, the corpus callosum, the CSP, the sulcation, gyration, the cerebral parenchyma, the posterior fossa, the walls of the ventricles, the calcifications, or whether there are any solid or cystic lesions that are present. Except for the neurosonogram, I would also look for other soft markers, because mild ventriculomegaly is a soft marker for trisomy 21. So the other soft markers
Detailed
for
extracranial examination to rule out any associated
and also
abnormality.
fetal infection, look for fetal
So
infection.
basically, you're looking at all this because you're thinking of the
Thinking
causes,
causes.
and the causes are which will, you will find all these findings.
So while doing ultrasound, what you keep in your mind, so you are searching for these signs. So can you enumerate the causes of ventriculomegaly? Especially mild ventriculomegaly we are
It
talking
should be
about.
divided, ma'am, because the
mild
causes mostly
ventriculomegaly.
different. The causes of mild ventriculomegaly, ma'am, almost more than 90% will be a normal variant. The fetuses will have a normal variant.
Provided you've proven it is
It is
isolated.
isolated.
yes.
After we have proven it is isolated. Ma'am, and the 5% are associated with fetal infections, and there may be some syndromes or fetal associated like trisomy 21, and some other rare syndromes, genetic syndromes can also be associated.
And it may be a part of very early onset progressive ventriculomegaly.
Yes, so a follow-up ultrasound.
So if you see, mild ventriculomegaly is one of the soft markers for, the likelihood ratios. And among all the soft markers, this is a very important soft marker that it needs evaluation. So that, in fact, the guidelines say that ventriculomegaly, you have to do
an
an
invasive testing.
Yeah, yes, sir.
So, Dr. Krishna Gopal sir,
Yeah.
will you suggest invasive testing? If yes, which test? And my another question, there is a very tricky situation, whether to go maternal torch serology, or if we are doing invasive, directly go for torch PCR.
Of the amniotic fluid.
Okay. So first thing is that what we are trying to look the causes. So we have a likelihood ratio. So we will multiply it with our existing risk assessment, and we will make a new risk that is called a priori risk. So whether this is high for aneuploidy or not. So first thing we will go for aneuploidy testing, of course invasive. Then we will look for the gestational age, set in which gestational age it is, and if we are trying to rule out chromosomal abnormality, because see, a ventriculomegaly is actually associated with both the chromosomal as well as genetic abnormality. These are two things, two groups. One is chromosomal abnormality, and another is gene disorders. So plus we will do a detailed ultrasound, like the neurosonography, and we will look for the signs of the infection in the brain, like the periventricular halo, like exudate in the ventricles. I would like to go for a CMA 750K karyotyping. I will also ask them that we may further go for the whole exome panel as well. So we will do the DNA storage for the future, and if it is progressing, then we might go for the whole exome as well. Third is if we are suspecting fetal, so it is better to offer them a torch as well, I think. Because if we will go for the maternal, then come back to the fetus,
So if you're going
that
to
makes
put a
no sense actually.
Because put a needle anyway for the chromosomal microarray,
So just adding one torch in your battery of tests is not only increase that much cost, but its coverage will be increased.
Wide spectrum.
Wider.
So,
but it's
Dr.
important to also note.
Ventriculomegaly, because we are suspecting fetal infection. So we can do the torch testing of the amniotic fluid as well. That's what we are trying to tell. Torch PCR.
Torch
PCR for amniotic fluid. That's what we are.
There are two ways. First is one thought is go for maternal serology, get torch IgG, IgM done. And second, if you are putting a needle inside, then why don't you are saying torch PCR directly in the amniotic fluid? Okay. Sir,
So we can
please,
do
can
the
you give your
torch PCR testing as well, with that fluid only. That's the advantage.
We should go in for an invasive, convince them, and once you tell them about the problems with mental retardation, global development delay, blindness and deafness, then they would automatically get this done. And then we tell them that, look, we don't need to do your avidity or your IgG, IgM for CMV. We will just go straight ahead and do a PCR for CMV. Yeah.
Thank you, sir. So, Dr. Krishna.
When do we start invasive testing?
Ma'am,
As soon as we diagnose, I mean, we can do amniocentesis after 15 weeks. We do it.
Do we start from 10 mm or do we wait till it gets to
More than
15
10 mm.
No,
When?
if you have defined this as a mild ventriculomegaly as well, so mild ventriculomegaly by itself, by definition, more than 10 millimeters within 15. So anything more than 10 warrants an invasive testing by itself. So anytime you diagnose that, you have to counsel them
And there is a one pinch here, that if you are doing our amniocentesis less than 19 to 20 weeks, the chances of getting false negative torch PCR is high. So we should keep in mind in this thing, if we are suspecting torch infection in any as a cause of ventriculomegaly, so better to defer it till 19 to 20 weeks.
So why she's saying is that because it takes 6 weeks
Yes, to-
for the amniotic
amniotic
fluid
fluid.
to test positive for the infection by the time the virus is secreted in the amniotic fluid. So sometimes if you do it early, you might get a false negative, and that you have to be aware and counsel the couple accordingly.
So Dr. Krishna Gopal, sir.
Basically, a viral load has to be built up in the fetal
Mother's
blood
blood, yeah.
so that they can excrete it in the amniotic
Urine
fluid.
and, yeah.
So this is the reason we will wait till 19-20 weeks. So this is the reason.
Dr. Krishna Gopal, sir.
Huh.
CMA report normal. Mild ventriculomegaly, CMA torch PCR report normal. How to follow up these cases? We are doing our
How do you
scan.
counsel them?
How to counsel them?
Counsel them.
And we have done our scan and amniocentesis at 20 weeks gestational age.
So we will counsel them that look, so far it is isolated, but we don't know whether that will progress or not, because cortical malformations, cortical issues may give rise to the progression of the ventriculomegaly as well. Fetal Medicine Foundation says that we have to do the follow-up every 4 weeks. Yes. But if it is increasing faster, so we can do the 2 weekly or weekly follow-up also, depending upon the increase in the size of the ventricles.
Thank you, sir. So to conclude,
Just a minute. And if it is persisting, then we will go for the MRI at 32 weeks.
Yeah.
32 weeks. Thank you.
So, look, answering your question, madam, that the severe ventriculomegalies, which is more than 15 millimeter, is usually a cause of an obstructive cause. And that will lead to more hypercapnias.
Hypercapnias.
And that accordingly, we sort of say that, the prognosis depends on whether it is progressive or not, and whether corrective surgeries will be required or not, depending on whether you see any other associated malformations also. No, because with obstruction you can have spinal defects, which are coming to that as well.
Equiductal stenosis or anything
Or
extra.
a spina bifida, which can be the cause of severe
ventriculomegaly. So to conclude, in most fetuses, mild ventriculomegaly is a normal variant, but there is a 9-fold increased risk of Down syndrome, and it may be the obvious early finding of cerebral malformation. It is unilateral in about 60% of the cases and bilateral in remaining 40% cases. And why it is important to know that when we are in most of the centers and many cases, we measure only far ventricles, and near ventricles are obscured due to reverberation artifact. And if we do not look at the near ventricle, we will miss 50% cases of the unilateral ventriculomegaly. But the greatest challenge in ventriculomegaly is to establish the cause as an isolated one. And when we will call that it is an isolated ventriculomegaly, so first we have to rule out any intracranial and extracranial abnormality, and in detailed ultrasound examination, additional finding is present in approximately 10 to 76% of the babies. Chromosomal abnormality must be ruled out by the invasive testing, and the infection should be ruled out by the torch PCR. When all these things are negative, then question arises, can we still call it isolated? We should call it apparently isolated. Why? Because ventricular dilatation is progressive in approximately 16% of the cases, and chances of getting additional abnormality at birth not diagnosed in the prenatal period is approximately 12.8%. So if our reports are normal, MRI can be done at earliest by 26 weeks, but ideally, as Sir Krishna Gopal sir said, 32 weeks. Serial ultrasound every 4 weeks. Neonatal development, neurodevelopment follow-up should be done. And in 90% of the cases, if the torch is normal, chromosomal microarray is normal, no associated intracranial and extracranial abnormality, the normal neurodevelopmental outcome is approximately 90%. Because it is not possible to determine with certainty that mild ventriculomegaly is truly isolated during pregnancy, normal variation is a diagnosis of exclusion that cannot be made with certainty until after birth. So proper counseling and documentation is needed in the cases of mild ventriculomegaly. Thank you.
No, 1 second. So anything you want to add, Dr. Gopal, that we've missed here?
Khurana sir.
And Sir Khurana, sir, here?
Sir,
On
sir, please.
ventriculomegaly?
Very commonly found and always a tricky situation, sir.
When did you do an MRI?
So when do we do an MRI and is it useful at all? We know that the cortical migration disorders will start at about 26 weeks and will have a profound effect on the outcomes. So therefore at 28 weeks then we would do our MRI to prognosticate a little further.
And follow up with a postnatal
MRI is also
That of
important.
course, yeah.
Thank
What
you.
I usually do is because a postnatal MRI would need anesthetization of the child, I like to do an MRI at 39 weeks or 38 so that the baby does not need to be under anesthesia for the MRI. Yeah.
So we go to another case scenario, which is then not uncommon, I would say. So Aishwarya just described this finding. It just, yeah. So here we are seeing the lower part of the fetus.
Yeah,
with-
we can see the cine imaging, and here we see that there is abnormal position of bilateral foot, where the foot is seen in the same plane as of tibia and fibula, with the foot being in adduction and supination. So this is a case of bilateral club foot.
Yeah. So again, like with other anomaly, Bhavya, what is your, this is a routine thing that we have to reiterate and tell ourselves again and again that one anomaly, what else?
Ma'am, once we find that there is club foot, we'll see whether it is unilateral, bilateral, and definitely we'll do a detailed TIFA scan, but with special attention to the neurosonogram, the cardiothoracic features, and look for other, again, some soft markers, because the
So what are the
associations of-
specific, we are saying that we have to look in general, but what are the specific organs that we're looking for,
Ma'am,
especially when you're looking at bilateral club foot?
Ma'am, neuromuscular disorders are common. So a neurosonogram and the spinal evaluation, the cardiothoracic evaluation is important because some kinds of skeletal dysplasia are associated with club feet. And the chromosomal disorders that are associated, they can be looked after.
Right, okay. So associated anomalies are common in fetuses with club feet, and obviously if you have them, that increases the risk of chromosomal and non-chromosomal, especially genetic disorders. So Dr. Mrinalini, do you think there are any specific causes for club foot, or that can be just isolated?
Ma'am, in 50% of cases, it is isolated congenital club foot. In the remaining, it can be a part of aneuploidy, it can be part of genetic syndromes, or it can be due to mechanical causes also like prolonged oligohydramnios.
Absolutely. So that's
or
something
any-
very common history. We have to look at the surrounding structures, not only the fetus, see if the liquor is adequate, if there is history of leaking or anything, and then see if there is oligohydramnios causing positional
Yes, ma'am.
club feet.
And Mullerian duct anomalies or amniotic band sequence, like
Yeah.
these things.
Pooja, do you think we can diagnose this earlier?
Yes, madam, at 12 weeks approximately.
So
Not
at
before
12
that.
weeks, if you diagnose, what will your approach be? Will it be any different from this, like when you find it at the TIFA scan?
We will do it by TVA scan,
That's one, and?
and a detailed evaluation is needed from head to toe to look for other associated anomalies also.
Yeah. Dr. Krishna Gopal, you want to add something there that, early diagnosis of club feet in the first trimester?
We should not haste. We should wait for it
Yeah.
to be
A proper diagnosis. Don't be in a rush to sort of call them again at 16 weeks if you want. Do a transvaginal scan, as we say, and a lot of time, more information is gathered rather than you start to prognosticate things at 13 weeks if there are associated findings which might develop, or you can see better at that point. So again, the same issues goes on, with any other anomaly. Dr. Pooja, do you want to suggest anything more? There is nothing here spine looks normal, the brain, the other organs, any other structures you would like to look at in terms of prognosticating this as well?
Means, madam, in this isolated club foot, the risk of aneuploidy is there, 1.7 to 3.6%, and it is also associated with sex chromosome aneuploidy. But in complex club foot, the risk of aneuploidy is 30%. So we should offer them invasive testing.
So again, the bottom line is any major anomaly, structural anomaly, especially if you see it in the first trimester, don't go ahead and do an NIPT. That is the first thing. Don't do a screening test. Do an invasive test to confirm if there is anything. But again, this is a correctable anomaly. First, look at the anomaly, whether this is correctable or not, and what information you would like to give the couple and the pediatric surgeon as to how to prognosticate this. And here we'll have our expert to tell us more, and what are the pitfalls in diagnosis as well.
If you go to the literature, even this kind of common anomalies, the chances of false positive is 10 to 14%. 10 to 14% is a significant amount. So again, we should not be in haste. We should not be in hurry. Basically, a diagnosis of clubfoot is made when the sole is in the same plane as that of the rest of the leg. So we have to be persistently seen. If it is persistently present that very position, only then we should go for the diagnosis of the clubfoot. One. Second is that we should also look for the issues in the brain, CNS, and the skeletal. We should also look for any amniotic band or the synechia. If you haven't that limitation in the form of maternal obesity, oligohydramnios, then you should also counsel them and please write it down, because in cases of oligohydramnios also you might see this kind of positions wrongly. You have to see the placenta as well as the amniotic fluid very, very carefully to make this diagnosis, because in most of the literature worldwide also the chances of false positive is as high as 10 to 14%.
And then again, you would like to involve the pediatric surgeons here if it's correct, if it's correctable to see. So they would like you to see if there are good movements along the knee joints, to see that is a better prognosticating sign, because then the issues with correction of the deformity becomes much more easier. Dr. Purana sir, if you want to add something. Okay.
So our biggest problem today is that genetics has changed. When we first used to have a clubfoot in the 90s, we used to say we'll do an amniocentesis because ultrasound is no good for associated abnormalities. Then ultrasound became very good by 2000. We say, okay, we don't need genetics. Then the exome era comes along, and then we say, okay, we do need amniocentesis. Now, there is no doubt that we need an amniocentesis. The thing with amniocentesis is that first we used to say, okay, we will do a QF-PCR or a FISH plus karyotype, which was the numbers of chromosomes. Then we realized we're not covering up the 250 cases sitting over here. Then microarray came along, and we said, this is very nice, it tells us much more, and we will pick up another 1,000 syndromes. But the 1,000 syndromes cover up only 40 of the 250 conditions. So we came up with the exome sequencing. And exome sequencing came along, and they said 45,000 rupees. Hello, no thank you. We would rather just sit and wait and look at our kismat. But what has happened is that we realized that the more we send to a lab, the cheaper it becomes. So what we've done in the last 1 week is to communicate with the genetics companies who are providing services here in Bihar, and we worked out a very special price for what is called the high-pass exome sequencing, or you have an option of a low-pass genome sequencing. Typically, these tests would have costed you between 45,000 to 65,000 for the lab. And what the labs have come up with is that they will give me a QF-PCR, plus, of course, a check for maternal cell contamination, and they will give us a low-pass genome, which is all the introns and exons, or a high-pass exome for only 20,000, which is really cost price for the world. Yeah. The only thing is that they can only do this if they have certain numbers. So the more patients we can convince, the better it is for the patient. But at this price, really, nobody should ever say no to genetic testing.
Absolutely.
And this price is valid for Bihar for a period of 6 months.
For Bihar?
Sorry, it's only for Bihar. Yeah. You know, what we want to do is to make sure that all of us who are growing up, I didn't know about exome until a year ago. So all of us who are growing up with these techniques should get the best opportunity. So this is only for Bihar at the moment. We will work on this, and if in 6 months down the line we can keep up a certain tempo, then it will be forever. So that is what we have done over the past 1 week. The companies Strand, they're outside on one of the tables, and you can take their number. All you have to do is when you send them an amniotic fluid sample, mention the SFM as a code, SFM sample, and you will get the special price. Yeah.
Sir, the problem is, the one major problem that I personally face, because I don't live in Patna, in Begusarai,
Yeah.
the major problem is of transportation.
Yes.
I have to pack the sample, then they get the sample to Patna, then they pack it again, and then they send it. So I get very, very worried about my sample.
You don't
So
have to,
there is
because really speaking, we're only looking at DNA.
Okay.
So nothing's going to go wrong
That
with that
is
sample.
nothing to
You can put
verify.
that DNA into an Egyptian pyramid, take it out 6,000 years later. It will give you an exome.
Sir, if they can like do something that they can directly transfer only one packaging at one place, if the company can do that.
Okay, we'll tell them to do that.
Yes, sir.
Very simple. And they'll make the packages and the tubes available free of cost anyway.
They do it. That
Yeah,
they do.
yeah.
Yes, sir.
We'll
So
do that.
big hand to Khurana sir and SFM for getting this for you all. You know, this is something very important, because as we are doing more genetic tests, we are discovering more problems that can be there, but let's do it all in conjunction with a clinical geneticist who can actually interpret the findings as well. So it's very
Correct.
important.
Yeah.
But you know, the more tests we do, the more the genetic syndromes that can come up is very, very important, because ultimately it is we have to give answers to the couple and not explain everything as idiopathic.
Yeah. So this price actually includes one session of genetic counseling
Okay.
for the couple. Yeah.
That is there. There you go. So that is all in a package. Yes.
The most important thing is you should give the silver lining to the parents. You should always make them understand that this is one deformity that can be treatable.
Correct.
And the baby will have a normal life. Because the first thing, whenever something we diagnose, the first thing that the patient think that we should terminate it. So whosoever is doing and making this diagnosis, they should just pass on this message at that very point, because the first counseling is the most important counseling. You should make them understand that this is, if isolated, if treated, this baby can have a very, very normal life.
So thank you for that. It's again a very important message that you liaise with your obstetricians, your fetal medicine specialists, your radiologists, the pediatric surgery, and important that we all speak the same language. Because if each one is giving different messages, the patient gets confused, the family is giving different messages. So, you know, if we liaise and we do a multidisciplinary, one combined clinic sort of approach, then the patient understands, yes, they are working for me and my fetus, and it is correctable and I can take it forward. So that is very important. Yeah, so to again conclude that in isolated, is there anything more?
This is perfect. Wonderful.
Thank you, sir. So in isolated clubfoot, you have to obviously detect an additional abnormality. In 8% of cases you can. And again, as we say, the risk of arthrogryposis can be detected later on. So you have to follow them up and, you know, and every time give a positive reinforcement, because that is important for the couple. They're very, very worried that whether my baby will walk, will run. You know, everybody wants them to be Michael Owens and stuff. So clubfoot may be the first sign of generalized neuromuscular disorders, so keep that in mind when you're doing it. So good outcome in most of the cases by conservative measures, just by exercises and, you know, putting them in special shoes, I can help them. Only 10% need corrective surgery, but it is correctable, that is important. And again, the recurrence depends on etiology, what the cause is found. So with one sibling, it is 3%. When if parents also have, then 25%. So we go to some two small, very common scenarios, very, very common soft markers that we see, and then we'll close the session for the like a rapid fire, yeah?
Yeah, it is like a rapid fire round. Dr. Mrinalini, can you describe the image?
I can see a cine loop of apical four-chamber view in which both the mitral and tricuspid valves are opening and closing. Pulmonary veins are entering into left atrium. I can see LA-RA, LV-RV, and additionally I can see two echogenic dots, one each in right ventricle and left ventricle.
Thank you.
One of the very most common things that you see, yes? So what is your significance, Aishwarya? Do you
So it is the most commonly encountered.
do you
thing.
put any significance to it at all, or you
Ma'am,
tell the patient-
EICF, I would say it does not represent a malformation, it is just a soft marker. That too has a likelihood ratio of less than 1. So if isolatedly present, and if there is, the chances of aneuploidy is less if isolatedly present.
is low, as
It is
we
a soft
Yeah, it is very low. That the chances of aneuploidy is low.
So, Dr. Pooja, what is your protocol for echogenic intracardiac foci in TIFA scan?
Whenever it is seen, we need to go for detailed targeted anomaly scan to look for other soft markers and also to look for other obvious structural anomalies. We have to look for the maternal age and we need to see the report of biochemical screening risk for aneuploidy. If it is a low risk, then in that case, the patient can continue the pregnancy because no need of invasive testing is required in those cases. And it carries a good prognosis.
Thank you, Pooja. Dr. Bhavya, isolated echogenic intracardiac foci, what is your suggestion?
Ma'am, if we have the, first we will see whether the patient has had any aneuploidy screening or not. If the patient has a report of a normal maternal serum screening, then we do not advise any further testing and we counsel them to have a normal ANC follow-up as any other patient. If she doesn't have any previous maternal serum screening, then we can offer her first cell-free fetal DNA if it is cost prohibitive.
For isolated?
Then, ma'am, in general, if we can
don't give,
offer them, not
So, she
then
can opt
a
for,
quad screen if the gestational age.
Okay, you might offer an NIPT to rule out chromosomal, but not because of the isolated
Yes,
foci. Yes, that is important.
Yes.
Okay, because if she's not had a previous aneuploidy screening and you want to test her for aneuploidies, yes, you might offer her NIPT provided you've done a proper scan. But just for isolated foci, please do not offer any NIPT. Yes, Dr. Gopal Krishna, you want to say anything? Or is it the most common cause for referral for fetal echo? Yes.
I must tell that soft markers are the bread and butter of fetal medicine specialists. Perhaps the bread only because there is no
Butter.
butter in fetal medicine practice. So it is a common referral of the detailed cardiac evaluation. But this is a very weak markers for aneuploidy and it does not require any further testing. Just give the reassurance to the patient itself.
It doesn't need any follow-up scans
But
also.
at the same time, we have different levels of imaging throughout our country. That is a very variable penetrance of the education. So I have an experience when an echogenic focus was referred later on in the pregnancy, 25, 26 weeks, and it turned out to be a rhabdomyoma. So we have to be careful. It is if it is done by someone who is following all the protocol and is good in walk and it is isolated, I don't see any reason to go for any further testing.
Thank you. Very clear-cut message there. So please don't get confused by echogenic foci.
So to conclude, echogenic intracardiac foci is a small, bright echogenic focus within the heart on a 4-chamber view. Ideally, it should be seen in at least 2 views. It is actually single, less than 3 to 6 millimeter. But there is a catch. Tissue harmonic imaging should be turned off, and gains should be lowered to prevent false diagnosis. And even in the euploid fetus, it is present in 3 to 5% of the cases.
Yes. So with the the advent of new machines, more things are picked up which might cause a false positive. So yes, another common finding of
Dr. Pooja, can you describe the image?
This is the transventricular plane of fetal head showing bilateral sonolucent spaces with well-defined wall seen in the echogenic choroid plexus of both the lateral cerebral ventricle.
Yeah. So just tell us the significance of the size, shape, unilaterality, whether it has any or not, and whether you would actually And yeah, Aishwarya, go on.
Yes, ma'am. So choroid plexus cysts, generally these are benign things and these are just infolding of neuroepithelial tissue. So when we have choroid plexus, it is a soft marker for trisomy 18, but I would say that the incidence of trisomy 18 is also very low. So if it is isolated, the choroid plexus cysts are isolated, so this is like the chances of having trisomy 18 is less if it is just an isolated finding. So we need to look at the other
Rather
structures
than,
also.
if you say incidence low, the thing is that with trisomy 18 and 13, you have other such gross abnormalities
Which
seen
should
in
be
the
looked
fetus,
for.
which you will not be able to. You shouldn't be missing them out on the
Yeah,
scan.
exactly,
Isn't it?
exactly.
So it will not just present as a choroid plexus cyst. Yeah. Yeah. So protocol in TIFA, Dr. Bhavya, anything more that we need to do?
Ma'am, the detailed TIFA scan is enough in a choroid plexus cyst. And moreover, ma'am, if for a follow-up ultrasound also, no specific
Yeah.
follow-up is required, a normal ANC follow-up ultrasound,
Yeah.
no postnatal evaluation.
In fact, if you see, it is not a soft marker for trisomy 21. If you see the likelihood ratio, it doesn't include the choroid plexus. It has all the others. So it's mainly for 18 and 13. And we've said, if you see outstretched hands, if we can document that, it more or less reduces the risk of aneuploidy. Nothing is zero, but is there still. So again, no change whether unilateral, bilateral, Nalini? Anything, any importance to that?
No, ma'am.
Bilateral size and
No, ma'am. It doesn't matter.
yeah. But if there is an isolated large CP cyst when the low risk of, do you have at all any significance? Because the patient को जब बोलते हैं कि brain में एक छोटा cyst हो गया, they are like, worried.
See, large cyst means how large it is. So there is one paper by the Palladini group, and that was very interesting paper because that was published, and then Malinger group put some
Addendum.
comments upon
Yeah,
this. Then Palladini replied it back very nicely. So basically, large is more than 10 millimeter outer to outer margin. So if it is more than 10 millimeter outer to outer margin, so the chances of having cortical malformations are more in this kind of CP cyst if they are persistent, if they won't resolve. Suppose you are seeing a 10 millimeter cyst, and in next scan it is 6, then 4, then 3, then 2, and then they vanish, because most of these CP cysts get disappeared by 28-29 weeks. So if it is persisting, so it is a good idea to get one MRI done at 30-32 weeks for the ganglionic cavities. In fact, in the cortex, that may happen, but that is very rare. What we see in our usual practice is a 3 to 4 millimeter CP cyst. It is not even more than 1 centimeter.
Absolutely. So this is just for theoretical reasons we put it, but the most common scenario is very small, 3 to 5 millimeters. Whatever it is, it doesn't. And 1 in 50 fetuses have this. More than 90% resolved by 26 weeks. So please reassure, and it has a good prognosis. With this, we end our panel. Thank you all the panelists and experts. And we invite one and all for our fetal medicine conference in Calcutta in April, which is FetoVision done with Foxy in association with the Society of Fetal Medicine. So please be there for, and requesting all your active participation. We have 4 international faculties. 19th and 20th is the conference. 20th afternoon, we have a 3D, 4D workshop and a live intervention workshop on the 21st. We have all our experts, Dr. Gopal, Dr. Purana, and everybody from Society of Fetal Medicine also. Thank you.
International faculties are there.
Yeah.
International faculties are there.
Like Dario Palladini, Dr. Mandeep Singh, and Dr. Leona Pun and Asma Khalil. So welcoming all. The registration is on the website. You can join, go into the website. So thank you, each one of you. Thank you, Dr. Gopal, for, if you have any burning questions, when the experts are here, we can sort of address them.
Ma'am, I have a question. Ma'am, I have a question.
Yeah.
Ma'am, sir, regarding that borderline definition that we use, the borderline ventriculomegaly that we discussed, if we have a patient who has a lateral ventricle measurement of 9.5 mm, say, so is it not better to report like
So as
borderline?
you said, prominent, and you follow. Yeah, you should not use borderline.
And we should follow up? Okay. And then follow up after 3 to 4 weeks without any further.
So you don't mention it as, you don't change the definition.
Okay.
You don't put confusing words. You say
Yes,
it's
yes.
prominent, you follow them up.
So we
Because
will
subject-
write prominent ventricles and follow up after 4
Yeah, and you have to follow them up because it becomes your responsibility to
Yes.
make sure it is not progressing or not. Yeah.
Thank you.
And please liaise with the obstetrician for them to send it back, send the patient back, because then they get lost.
One question I have, it was a very informative discussion for the obstetrician also. If it is bilateral club foot, then what is the prognosis and what should we advise if it is bilateral? Because one case I had and they advised termination of pregnancy, is it correct?
No, ma'am. Basically, even in the cases of bilateral club feet also, so this has a same kind of correctable surgery, that is putting the feet into the cast and all these shoes, and they can be corrected. The only thing is that we need to rule out the associated chromosomal abnormalities. So we must offer them invasive testing, try to rule out all the chromosomal abnormality, then we can assure them that if treated correctly, these babies will have a normal life.
Okay, because she was told that it can have neuromuscular conditions also, so she was advised termination.
Ma'am, if the feet are moving well, if the legs are moving well, and at the knees flexion is there, extension is there, all the movement, and if you are rolling out all these associated chromosomal abnormality, then the fetuses are having normal outcome.
Thank you, thank you.
So thank you once again, and I thank Ashika.
I want one.
Yes, madam.
Not exactly question. It is not related to ultrasound, but a general question about a patient. Since you are dealing with fetal medicine, that's why I thought I should ask you people if you could give any comment. I have one patient who has 5 children, who are alive children. 2 male and 1 female died after within a week of birth due to fever or something, the same type of disease. All of these 3 children got. And now she is very scared whether to go for pregnancy or not. Although she is going to have her 6th child. On whole exome sequencing, the male partner was found to have variants of certain genes. And the female partner has got thrombophilia trait. She is carrier of thrombophilia. So, have you got any suggestion for that patient?
So a lot of these conditions, a lot of these conditions could be, you have to see the genetic profile as you've said and see whether it is clinically, it's pathogenic or not, and then it is, and and with the geneticist input here, whether the penetrance is variable or not, how it is going to be phenotypically affecting. A lot of them have also got inborn errors of metabolism. They typically die within the first week of birth. They have these recurrent neonatal deaths. So that also needs to be ruled out. So it is a difficult scenario, but with proper genetic evaluation, if that is not really pathogenic, then we can tell them that this inheritance pattern will be less. But again, it will be depending whether it is homozygous or heterozygous. It depends on that. And whether the mother is also affected, yes.
Ma'am, whenever you people get these reports, so every lab has a responsibility for the post-test counseling also, whether it is normal or the abnormal. So and nowadays when we have all these online things also going on, so this patient can demand from that very lab that they can get the counseling as well as the pedigree drawing for their family. So this will make the situation much more clearer, and we will of that knowledge where we can do the justice to the couple. So whenever you will get any report where you have a doubt, so that very lab has a responsibility to arrange the genetic counseling of the couple also, preferably online at least, because even the top people in the field of genetics, they are available for the counseling online also in these cases. Yeah.
Yes.
Basically, ma'am, if there is a ban, No. If
No, there are two different
first, there are different things. Whether that is septum placental synechia or it is a two band. Bands are very thin. They can be multiple or multiseptate. So they can cause auto amputation of the limb, and they are one of the causes of litigations also. You should counsel them. You should give them written counseling that in view of the amniotic band syndrome, the chances of having auto amputation of the limbs are also there, and this kind of prognosis was well described to the patient and companion. No. They should see, termination of the pregnancy is not the doctor's job. Our job is to give the prognostication. If knowing the prognostication, if the patient gives us request for the termination, then only we should
typically
terminate
these,
the pregnancy. See, actually, if I'm seeing a single band, and if I'm seeing that the limbs is not stuck into it, then I will ask for the follow-up after 2 weeks or so. Or whether that bands is developing. Sometimes they are so microscopic, they are not seen by the naked eye at that very moment, and they might appear in the next scan as well.
So typically these amniotic bands are very thin, floating, stuck to the fetus, and the fetus moves along with the band, so these cause amputation syndromes, whereas the other one, the synechia, they are very thick, and the fetus is completely free from it. So we do additional transvaginal scans and sometimes see if there is actually an amniotic band, because they have much more serious implications than the synechia itself. And a lot of these synechia are wrongly labeled as amniotic bands. Absolutely, yes. Absolutely, yes. Yeah. Thank you for that. Thank you all the experts. Thank you Aishwarya, Mrinalini, Pooja and Bhavya, and Dr. Gopal sir. Thank you.
I would request Dr. Sita ma'am.
Dr. Ashita for doing all this. Thank you.
Dr. Sita ma'am for the next talk.
Okay,
thank you. Dr.
कर लीजिएगा और इन दोनों को आप इनवाइट कर लीजिए। I would request for the next session, I would like to invite the chairpersons, Dr. Kumkum Sinha ma'am. She is a consultant obstetrician and gynecologist, Subdha Clinic and Ultrasound Center, and President Patna Menopause Society, past President POGS. And I would like to invite next Dr. Alka Pandey ma'am. She is immediate Vice President Foxy. Dr. VB Golwara. She's not here. Dr. Savita Rungta ma'am, as a chairperson, please come on the stage. and Dr. Shipra Singh ma'am, Shipra Roy ma'am, as a chairperson. Over to you, Sita ma'am.
Thank you. Thank you. Thank you. Thank you so much, chairpersons. I'll go straight to the topic. I don't need any. So it's all
Okay, everyone knows that you are the chairperson of imaging committee.
Genetics
Foxy.
and medicine. Genetics and
Genetics and imaging.
fetal medicine. Thank you. So again, a very common topic that we see in
So
our
the
day-to-day
topic
practice.
today is FGR when to deliver. Over to you, Madam
Thank you.
Speaker.
Thank you, madam, and that's me for you again, and thank you once again for all the warm hospitality in this cold day. So when we talk about FGR, we all know, because it's worrying, that the outcomes are what are worrying, because it has an increased risk of perinatal morbidity and mortality, and there are, again, the most common cause of iatrogenic prematurity with its associated outcomes, prematurity associated complications, and the most important thing is especially in early growth restriction, there was neurodevelopmental outcomes and the long-term effects of these children having a risk of non-communicable diseases in the future. So when we correlate FGR and stillbirth, we see that most of the causes of late unexplained stillbirths are actually growth restricted. So 30% of stillbirths are actually growth restricted, and only 11 to 20% that end in stillbirth are detected. So it is there we are failing to detect these late FGRs, or the ones who have ending up in a stillbirth, and that is what we are doing. And this was studied by Leona Poon, who said that 70% of babies dying at term are not small for gestational age, and majority of term stillbirths are not small for gestational age, which means that we are missing that average for gestational age, also the group of fetuses who have not actually grown and ending up in stillbirth. So what is growth restriction? It's a dynamic process. We don't sort of see that whether the baby has grown at one point. We have to serially follow up the fetus to see if it is growing. And it is important to realize that every fetus has its predetermined genetic potential. So it's not the same for every fetus. A mother who is healthy will have a healthy child. A mother who is small built will have a constitutionally small. So it is that fetus's genetic predetermined potential which will tell whether the baby is growing as normally or not. And usually the unfavorable conditions is placental insufficiency, and that is what somebody has rightly said, that placental insufficiency is the umbrella that covers our ignorance for these growth restricted or placental dysfunction, because there's much more than placental dysfunction that we need to see for these growth restricted women. So when we talk about growth restriction, we have to identify the key issues in improving outcome is to identify those fetuses at risk of deterioration, and then see what is the most appropriate surveillance, and then determine the delivery. So when it is a high risk mother, she has a high risk fetus, we are not worried. It's a low risk mother, it's a low risk fetus, it's okay. But if it's a low risk mother and a high risk fetus, which tend to get missed, and that is what our aim is to find out. So we all have our clinical surrogates. We take a detailed history, very important. You take the risk factors. We still rely on our symphysis fundal height. It is important clinical marker, more than 3 centimeter, but yes, we know it is unreliable, especially if the mother is obese or she has other problems. And another thing that has come up in the latest guidelines is all our low-risk women, after having the anatomy scan, should have a 3rd trimester ultrasound assessment for growth at, if possible, at 32 and 36 weeks. But if one scan is done, preferably at 36 weeks, that is what the recommendations are. But we would say 32 and 36 weeks. And along with that, always combine it with a Doppler assessment. Never have a report of a growth with just biometric parameters. Always include the Dopplers. So for me, as I say, every anatomy scan is a growth scan, and every growth scan becomes an anatomy scan, because you tend to see both the pictures in one thing. So the biochemical markers will give you a risk. When you look at the first trimester screening, anything of, as I said earlier, PAPE less than 0.4, low PLGF. If she has missed the first trimester screening and she's come to the quadruple screening, even the high AFP, which was usually suggested for spinal cord defects, spinal bifida, you should be able to pick them up on ultrasound, but yes, it is also a marker for growth restriction. And of course, we have the biophysical markers, like we said, the uterine artery PI, sometimes if there's a single umbilical artery. These are all telltale signs, so look at the report. Don't just look at the final report. Look at the variables, what they're trying to tell us, and don't go by whether it is high risk or low risk. And these are all usually predictive for early onset FGR. So not needless to say, whenever you're assessing growth, as Dr. Khurana sir had said, please ensure you have a correct gestational age assessment by a correct dating scan done at the right time in the right way. So even when you're looking at the dating scan, look at the image if the CRL was taken care of properly, because a wrongly done CRL, as we've seen, can increase the errors when you're estimating the gestational age at term. Always plot the growth on charts. Don't go by, and once you assign the EDD, don't change the EDD. Every time the lady comes, when you have assigned it by CRL or by ART, whatever method, every time she comes for an ultrasound, put that EDD and then decide how the baby has grown according to that EDD and not according to what the ultrasound is telling us. Because every time the ultrasound is a machine, whatever figures you put in, it will give you a gestational age corresponding to 33 weeks, 34 weeks. The patient is confused, the obstetrician is confused, everybody is confused as to where her EDD is. So once an EDD, never change the EDD. And use the graphs to plot. It's all available on the net as well, and you have standard charts, but whatever chart you're using, use the chart, use one chart and continue using that chart. So your machine has your Hadlock charts. If you're happy using that, use that, and the charts should include HC, AC and FL, and not the entire, not BPD and FL, or not separately. Ideally, they should be covering AC, HC and FL, and it is the rate of change of these parameters we are assessing. And any fetus that is less than the 10th centile for that gestational age is what we are going to pick up as high risk or needs monitoring. So by definition, what is small for gestational age? Actually, the word small for gestational age came for postnatal, neonates, they were according to term, but that has been translated to antenatally. And yes, those which have an estimated fetal weight of less than the 10th centile on standard growth chart. So they could be either normal, SGA, or pathological, that is FGR. But FGR is what? Is when there is growth less than the 10th centile associated with Doppler abnormalities, or even if there is one measurement of the AC or expected fetal weight less than the 3rd centile, which is itself, by itself, and enough to label this fetus as growth restriction. But at the same time, as I said, because it is every fetus's genetic potential, a baby that is growing on the 75th centile on the anatomy scan, if it is growing on the 32-week scan on the 20th centile, it has actually dropped by 2 quartiles. But by definition, it is still above the 10th centile. So it is not falling in the definition, but it has fallen by centile. So that also needs monitoring, and that is what you need to look at. So don't just look at the report, look at the graph, make sure that the anatomy scan has been plotted and the growth scan that you're doing now is also plotted, so that you can see the trend in which the baby is growing. And yes, this can happen in SGA fetuses or, as I said, appropriately grown. And then when you phenotypically divide them, you can divide them into early or late depending on when you're picking them up. Because the early growth restrictions are when you pick them up before 32 weeks, and late is when you pick them up after 32 weeks. So once you've found out that the baby is small for gestational age, you have to decide whether it is a constitutionally small or abnormal small. And here is where your Doppler parameters come into help. So you have to have every report with Doppler findings, and you have to do both placental and fetal circulations, that is the uterine artery, umbilical artery, MCA, ductus venosus, as and when the situation demands. So this is again a classification that has come up, that once SGA is diagnosed, you do use the fetal Doppler indices and their ratios, and if the uterine artery Dopplers are normal, you can classify them as something called low risk SGA, and you can call them every 2 weeks. But if the uterine artery Dopplers are abnormal, you classify them as high risk, and then you call them as for weekly Dopplers. Because SGA with normal Dopplers can also be associated with accelerated placental aging, so you can't just ignore them and say that everything is nothing to worry about. And then in these SGA fetuses, you consider delivery after 38 weeks, but it should not exceed 39 weeks is the bottom line. So if your growth is less than 10, all the Dopplers are normal, you can wait up to 39 weeks, induction depending on the clinical situation, and of course continuous monitoring during labor. But if, as I said, if the growth restriction is less than 10 centile, if the fetal weight, and it has any other abnormalities, that is even if one measurement is less than 3rd, or if the uterine artery PI is more than 95th centile, or the CPR is less than 5th, that is the MCA upon the umbilical, you label them as FGR. And now they have also added in the West the PLGF to see if they can corroborate with these findings, but that is a space yet to watch for. So phenotypically, we have divided into early and late, and early is where there is severe placental insufficiency, that the placenta is not able to cope with the growth right from the beginning. And these are typically diagnosed early, and they have other problems like genetic problems or infections, and they are very easy to pick up because they are obvious. You can see that the baby is grossly growth restricted, but they are difficult to manage because we are dealing with limits of viability, 26, 28 weeks, depending on what neonatal backup you have. But with the late growth restriction, it is a maturational process, and here the placenta is not that damaged. The baby copes till 31 weeks, the placenta copes till 31, 32 weeks, and then it is not able to sustain the baby's growth, and that is where the baby growth falls, and so the Doppler parameters may remain normal till end. So Delphi consensus have classified this. I'm sure you all know this, depending on what we find, that is the early, in the absence of congenital anomalies, 1 parameter less than third, or less than 10 combined with uterine artery PI or umbilical artery PI above the 95th, whereas late FGR is anything less than third, or at least 2 of the 3 of the following, that is less than 10th, along with crossing centiles or umbilical artery PI above 95th, or CPR less than 5th. So when you time delivery of all these, it's a delicate balance, because you don't want to have a stillbirth on your hands when you're monitoring these babies, and at the same time you don't want to give an iatrogenic prematurity either early or late, because even 34, the late preterms also have problems with neurodevelopmental outcome, and you want to give an intact survivability rather than just a live baby to the couple. So when you monitor them, again reiterating, you have to do a growth scan at 32, 36 weeks and evaluate fetuses, and the ones which have a drop in velocity and fallen centiles, you will follow them up. And along with that, you do a Likert assessment, you do a Doppler and biophysical parameters. Why I have put Likert? Because Likert is a chronic marker. It is reduced in FGR, but please do not deliver babies just based on the low Likert volume. If your Likert is low, and if your Dopplers are normal, you can continue the pregnancy. Another very common reason of iatrogenic prematurity, the minute you see that the Likert is low, you tend to deliver them. You put them on the graph, you will see even an AFI of 5 is normal for 36 weeks, so you can continue them if everything else is normal. So there is limited evidence for the role of oligohydramnios, so its inclusion in management protocols is actually questionable. Uterine artery we've seen as predictors for preeclampsia FGR, but also when you have a baby with FGR in the 3rd trimester, if you do uterine artery Dopplers, it has been shown that if the PI is more than 95th centile, it says that this baby can have a poor perinatal outcome, so you need to follow them up more. So it doesn't have a role just in screening, it also has a small role in prognosticating these fetuses. Umbilical artery, typically it will show you a normal forward flow, and as I said, it will become abnormal only when the placental damage is more than 30%. So in late FGRs, where the damage is maybe less than 30%, you will not see any umbilical artery Doppler abnormalities. And that is the caveat, and that is the pitfall we may have. Again, plot all of them on charts rather than the absolute values. MCA is the baby has blood supply to the brain only in restricted conditions. So normally you will find a high resistance flow, and if there is a brain sparing effect where the circulation is redistributed to the brain, then you will have a flow something like the umbilical artery, and that shows that there is a problem going on. But it should not be purely based on MCI that you decide delivery both in early and late. So, and here is where the cerebroplacental ratio comes in, where we put in a ratio of the MCA versus the PI, and that may reflect hypoxia, and that becomes abnormal before the MCA because it is a ratio, and as I said, the umbilical artery may remain normal. It will only the CPR that becomes abnormal becomes significant. So it should be used in conjunction with growth velocity always. But again, their studies have shown that abnormal CPR at term for appropriately growth gestational fetuses, there is a higher risk of these women undergoing cesarean section for fetal distress and higher NICU admissions. Ductus venosus Dopplers is an element of cardiac function we look for, so it mainly comes into play when we are looking for early growth restriction because we want to prolong these fetuses as long as they can, and then when there is an element of cardiac dysfunction, we want to deliver these fetuses before they are actually very, very sick. So it remains normal in late FGR because that is not what we are looking for, and because the cardiac function is not compromised in the late FGR. And what are the other parameters? Typically, we look for Likert volume, but not purely based, delivery based on that, but you have biophysical, especially in that the breathing movements. So breathing movements come into important in late FGR, where the hypoxic status is reflected by the fetal breathing movements, which is reflected in the mother perceiving the fetal movements. So listen to the mother when she says she has reduced fetal movements, because that is a telltale sign the baby is not breathing, the baby is not moving, and is beginning to become sick. And here is where you will use your CTG. If you have computerized CTG, which we don't have in most of our settings, you will put in your CTG as a net, safety net, so that in between scans, you can sort of call the mother for a CTG, and that will show you whether the brainstem is actually working well and whether this fetus is hypoxic or not. So, as I said, early FGR is actually good because the latency period is quite high. The baby prolongs, it stays like that for weeks, and you can prolong the pregnancy. But a lot of time, the obstetricians, the mothers, they get worried, and you tend to deliver them by 30 weeks, and that is a disaster because it is a preterm and it is growth restricted. So please don't do that. Actually, the early growth restriction, the Doppler abnormalities may persist for weeks. So you have this because every day improves the survival by 2%. So before you put in a knife, please think whether if I could have waited for one more day, how much it would have benefited the cost for the couple and for the entire family. And yes, the Trufel study said that the timing of delivery was based on ductus venosus, Doppler measurement. So you can, if you have the facility, even if, because typically the early growth restriction tends to follow a pattern. The growth falls, the umbilical artery becomes high resistant, becomes absent, becomes reversed, and then the ductus venosus. And there is a latency period. So if you call them, if you're able to follow them up, if the lady is compliant, if you have skills to do the ductus venosus, you can wait till then and deliver till the ductus venosus become abnormal. But a lot of time in these patients, what happens? The women itself have high risk. They tend to have preeclampsia. They tend to come up early. So you tend to deliver for maternal reasons rather than fetal reasons. So that is what it says here in the delivery criteria, that is late DV changes or a computerized CTG. Rather, what we tend to look at is spontaneous decelerations, unprovoked decelerations on CTG, which is an ominous sign for these growth-restricted babies. And for umbilical artery Dopplers, I'll come to that. And of course, if you have maternal indications, please don't wait if she has help. So as I typically describe, is a typical cascade of events that happens in growth restriction, and we no longer look at aortic ischemic Dopplers. So early growth restriction, this is what your latency time is. If there is increased uterine artery PI, you actually have 28 days. If there is hypoxic, that is absent end diastolic flow, you have 21 days. The baby can actually survive for 21 days, provided you monitor them properly. If there is suspicion of acidosis, which means if there is reversed end diastolic flow or the DVPI is more than 95th, there will be 10 days latency time. And if it's reversed, you only have 4 to 7 days. If there is CTG abnormalities, it is actually within hours. So you can actually see that how this baby is progressing. You can monitor them and tell the patient, yes, you have time, but please follow up and don't just give up on us. So, and the other important thing is that biophysical profile and CTG changes appear late. So you shouldn't be ideally waiting for that to happen and deliver not so sick fetus and give a sort of a fetus which is manageable by the NICU. Late FGR, it is not restricted enough. So as I said, they are more mature fetuses, so they're more susceptible to hypoxia. So any changes in circulation, the brainstem reacts quickly and they tend to have a sudden deterioration, and that is why we tend to have a late stillbirth in these late growth restricted fetuses, which you may think it is abnormal. So suddenly, typically the lady will say, I didn't have any fetal movements yesterday, but if you actually go back to see, or if you have had ladies who've had a previous stillbirth, please ask what the weight of the baby was, because it could have been a growth restricted fetus, and that is what was the cause of that late stillbirth. So this is the stage-based classification which the Barcelona group, Gatacos group has given us, and we say that if there is severe smallness, you tend to monitor them weekly, but if the Dopplers are not so bad, you can go up to 37 weeks. But if the umbilical artery PI is more than the 95th centile, you should ideally be delivering them at 36 weeks and not later. Of course, with other things, you have to monitor them twice weekly or daily, depending what the Doppler abnormalities are. And then if it is absent or end diastolic flow, you deliver them at 34 weeks. If it's reverse, at 30 weeks. And if it's very, very early preterm, depending on the setup, most of our patients will not agree to have, but you must have a neonatal consultation as to what the cost implications of delivering such a preterm baby are. And don't forget your steroids. Please give steroids only within when you are planning your birth within 1 week, and for these preterm infants, I've not covered that, use Maxulf as a neuroprotector in the same dose as you would do for eclampsia. So this is typically a case. We had a lady, a 24-year-old, primigravida, intermediate risk. She had a PAPI of 0.1. And at the anatomy scan, her growth was less than the 5th centile. So that is worrying. So think other than, just don't assume that it is growth restriction. So we did an amnio. It was a normal CMA infection screen. And we tend to follow her up. The basic message here is that we could continue her for 33 weeks, and the baby was a 1 kilo baby which the neonatal care could handle. Yes, we delivered her because of PET, and then she had absent end diastolic flow, but the ductus venosus tend to be normal, and then as she continued, she was a very compliant patient, we could and the baby is safe and well now. So, that is also important. Whereas this lady was all going well, the growth dropped around 34 weeks. My marker is not seen, and the middle MCA PI dropped as well. The CPR kept dropping below the 5th centile, so typically she came in with reduced fetal movements. We could have possibly, waited, we don't know, but yes, she delivered a 2.2 kilo, which was also fine. So this is, So among all the guidelines that I've seen, I felt that the ACOG guideline is sort of more practical. I don't know if you can see, it's a very busy slide, but you can go onto the net and it sort of gives you an easier classification and algorithm as to how to go about it. You see whether it is early or late, you depend on whether you do an infection screen and how to monitor them. But the take-home message will be, and this was another study by the Gatacos group where they found that in SGA babies, they did a 10-year follow-up study, and they found that only 9% of low-risk SGA pregnancies switched to FGR. So if you are having an SGA baby with normal Dopplers, you can monitor them every 2 weekly. Another important message, don't call them for growth scans in less than 2 weeks. You're not going to be able to assess the difference in growth. If there are Doppler abnormalities, call them every week. But for growth, give them minimum 2 weeks to assess if there is actually being a difference in the growth or not. But when FGR is suspected, you have to do more intensive monitoring. So they said that a protocol-based risk stratification actually enables identification and tailors assessment, and you can have expectant management with safe perinatal outcome for these low-risk SGA fetuses. And this was the latest study which on the Lancet which was a study based on the CPR on open randomized trial based on all participants undergoing ultrasound at 37 weeks with growth and Doppler, and both of the delivery was planned when the estimated fetal weight was below the 10th centile. And they said that planned delivery based on fetal growth assessment and CPR was not followed by a reduction in perinatal mortality, but it significantly reduced severe neonatal morbidity, so it does still have a role in delivering these fetuses CPR at term. So the bottom line is identify these small fetuses, you distinguish between SGA and FGR by the criteria as I said. SGA, you don't go beyond 39 weeks. FGR stage 1, 37 weeks, you monitor them weekly and deliver them at 37 weeks. Stage 2, 34 weeks, you monitor them twice a week. Stage 3, 30 weeks, and stage 4 is any time. And please, no role of preventive aspirin, prenatal aspirin and low molecular weight, and absolutely no role of sildenafil or activity restriction in cases of early growth restriction. You're going to land up in more problems with thrombosis and other events. So key messages is a uniform approach, antenatal surveillance, identification of appropriate delivery thresholds, and in early FGR, your ductus venosus should be a trigger, whereas in late, your CPR might be your determining criteria. Thank you so much, and again, inviting you all for FetoVision. Thank you.
Now I would request
Hello.
Dr. Ashok Khurana sir.
This was a very nice talk given
Thank
by
you,
you.
madam.
It is open for questions for anybody. And I want to ask you one question. In these cases of FGR babies, how early can you think we can deliver them and give them prognosis that they will
So
survive?
it all depends on what your findings on ultrasound are, what is the maternal condition, how much the baby has grown. So a lot of things will depend. So you can't generalize it for everybody. You have
No.
to individualize.
But still, in your setup or any tertiary care hospital,
We-
how early?
So we want to go till 32 weeks, minimum 32 weeks. But if it is
yes.
very, very severe, like the lady has APLA and it is not growing well, you have to tell them that it is no point. But we don't tend to terminate them. We tend to say that nature might take its own course and maybe she'll have an intrauterine fetal death. It is very, very early growth restriction. But yes, it's always better to, follow it up and
Yes.
give the benefit of doubt.
Because there was one incident where we predicted that it was only 28 weeks, but the parents also wanted to have that baby, and they compelled, and then of course the prognosis was that it survived only for 3 or 4 days.
Yeah, so it is very important to counsel them and give them the clear picture.
Yes.
If you have a 500 grams at 28
Yeah.
weeks with all Dopplers are abnormal, the prognosis is very bad, but you can't sort of say terminate it.
Thank you so much.
One question.
Since ma'am is in, acha, ma'am, please.
Uterine artery pulsatile index should be asked for by us at as early as 12 weeks.
We do it at 12 weeks, 20 weeks.
As a routine screening. Okay.
Since Seetha ma'am has a flight to catch, we will like to felicitate her. We will call Dr. Ashok Khurana sir to please come on the stage.
Thank you.
I would request Dr. Manju Gitra Mishra ma'am to please come on the stage and Dr. Ashok Khurana sir to please felicitate ma'am. Thank you, sir. Thank you, ma'am. The chairpersons to please remain on the stage for the next session. I would request the chairpersons to please introduce our next speaker, which is Dr. Ashok Khurana, sir.
एक सेकंड बेटा हम ये कनेक्ट कर दें पहले.
We started with sir and now we have the pleasure to have the last talk also with sir.
Laptop gets set. We have one more thing, and it's a very good piece of news, which is another offer from our trade partners who are sitting outside, both M-Fine LifeCell as well as La Lab has decided that, again as introductory course, because we really feel that PLGF should be done for everyone, at the cost of their double marker, which is PAPE plus free beta HCG, they will do a free PLGF, which is for 3,000 rupees only. Yeah, that's half the story. For everyone that comes high risk on this, what is now called the first trimester triple, the free beta HCG, PAPE and PLGF, they will give you a free NIPT. And for every positive NIPT on the amnio, they will give us a free QFPCR. And again, this is only for Bihar. Yes. So I can see that if we have a few more of our programs here, we're going to be quite happy with what the companies are doing for us. So I am so looking forward to that. I will just take a second to get this organized once again. And there we go. Yes, now
So we have the next session. that the speaker is none other than our esteemed speaker, Dr. Ashok Khurana. He is going to talk on aneuploidy screening, navigating the maze. Over to you, Dr. Khurana.
Thank you. It is indeed a pleasure to be here, like I said, and I'm so glad that the trade is coming forward to actually manage this for us. Ye signal aaya aapke paas? Haan. Oh, so there we are. And we've heard a lot about aneuploidies during our discussions today. I will summarize all of this so that we can all carry this message forward and use it until our next meeting, until which, of course, knowledge might change. So what we will do is to go through this talk. I've had a few update ideas from Ravi Shawi, whom you know is my guru, and he has also helped me out with this talk. So we will put all of these observations together. What we do is, of course, the mainstay has always been this thick, loose skin at the back of the baby's neck for all individuals who have Down syndrome. And you will notice that a lot of people don't have Down syndrome when they have this. So I have a lot of loose skin here, but I am not Down syndrome, yes? Then they used to say you have something called a simian crease, a single line across your palm. Have you ever seen that? Like this. Correct? So this has been the problem, that you have these things called markers, which are there in normal individuals, and they have a higher frequency in abnormal individuals. And you and me are supposed to be magicians to decide which person with this simian crease is not so bad and which one is Down syndrome in terms of intellectual abilities. And therefore we will go about this. Again, technology, if you notice, this is an ultrasound of the NT, the nuchal translucency mid-sagittal plane, where we are not only seeing the outlines very nicely, but we're also seeing the grayscale at the same time. Normally when you get your NT images, you will notice they're very black and white. Here they're grayscale. This again are the newer ultrasound machines which give you grayscale and contrast and outlines much better. And the difference in the cost is not very much. So I will take you through the first question first, and that is, what is the hurry? Why are we pushing this whole business at 12 weeks, and why should we be doing this? Well, first of all, when we're going to diagnose the aneuploidies, they are much better detected at the 11 to 14 weeks window rather than the 16 to 24 week window. So we should be doing that. All of us know that in case the patient opts for a termination of pregnancy, it is easier, safer, and psychologically much more simple to go through compared to a late termination of pregnancy. We also use this, of course, for dating of pregnancy, for the stratification of twin surveillance, you've heard that today, the early reassurance to mothers who are at a clinical high risk, and it gives us enough time for genetics, which seems to take longer and longer because it's getting smarter and smarter. Then, of course, we also are able to identify our patients who are at a high risk for preeclampsia, start their treatment before 16 weeks, put them onto 150 milligrams of low-dose aspirin at night, and prevent most of the eclampsias, especially the serious early onset ones. So I will take you through a relevant perspective of the aneuploidies evaluation. We won't take you through a how-to of ultrasound images. Here we are now today not just inaugurating what we call the study group, because that was for any organization that has more than 70 members. So we had a study group until this morning, and thanks to all your cooperation, we will now actually inaugurate a regional chapter, for which you will get a notice on the WhatsApp group. So thank you very much for being a part of us. And so we will form this group, and then, as usual, we will have a democratic election process, etc., etc. But the how-to will be based on workshops which will be hospital-based, which means we want volunteers to come forward so that we can have people watch this in real life. They can see interventional procedures, they can have exercises, case studies, and a 1 or a 2 day program on how to actually obtain these images at 12 weeks. And that is what we plan to do in our quarterly meetings and in our outreach programs. The outreach programs will be confined to cities where we really have a lot of difficulty in getting people to come out from there because they're working 7 days a week. So we will try and go and reach them and say, okay, reserve one Sunday for us and we will come and teach you all of this. It will depend completely on local teams and not on central teams. So we really look forward to your cooperation for all of that. And I will now take you through a real-world approach to this first trimester stuff in terms of structural anomalies that immediately require not screening but diagnostic testing, and of course chromosomal markers. But first things first, please do remember that when it comes to these chromosomal considerations, the end point of the first trimester evaluation for Down syndrome is usually termination of pregnancy. Most parents all over the world look for prenatal options in the scenario of an abnormal fetus, but there will be some who would never terminate the pregnancy, either for personal reasons or religious reasons, and we must respect that and tell them that, look, if you're not going to terminate this pregnancy, please come back at 21 weeks for your anomaly scan, and we will see that there is no anencephaly. The rest of it, the world will manage. So our role is to provide these options. So we must be sensitive to these things right in the beginning. Then we must also realize that a lot of the first trimester stuff is not a diagnosis, as you have heard today, but is actually a process of screening. Screening means that we try and look for a population that needs further testing to confirm or exclude an abnormality. So if I'm screening, I will not detect all the abnormals, and it does not mean that whoever is screened positive will be abnormal. They are the ones who will have to go through a further testing. This takes up a lot of time, energy, personnel and expertise, but it is your duty and mine to do it, and pre-test counseling becomes extremely important, and therefore we must do pre-test counseling with appropriate time. We'll also remember that tests in India are usually paid for by the patient, and therefore we travel all over the country trying to identify local good laboratories which will provide us reliable service. Even for NIPT, there are now companies coming up which don't do NIPT in the correct way. What they do is that they will not even collect the sample in what is called a Streck tube. A Streck tube costs by itself over 1,000 rupees. And these companies are collecting it in an EDTA tube and doing a test that gives me a 90% detection rate. It makes no sense. 90% detection rate I'm getting just by doing NT alone without doing even the rest of the scan. I need a reliable NIPT that gives me a 99.6% detection rate. And that will be possible with the help of these trade partners. There are two of them here. There is Lalpath Lab, and there is, of course, M-Fine, which works with the Saral company. Now, what we will do after we have screened is to give the patient the options all over again and say that, look, we have to confirm this and you need an invasive procedure. And at the 12-week window, that is a chorion-Willis sampling, which is obtaining tissue from the future placenta and sending that off. But do remember that a chorion-Willis sampling consists of placental DNA and not fetal DNA. And occasionally, they may not match. So you have to give the patient the option that, look, there is this thing called mosaicism, very, very rare, but it does happen once in everybody's lifetime, where the fetus is completely normal and the placenta showed Down syndrome and vice versa. So some patients might say, okay, in which case I will do an NIPT now and we will see at 16 weeks what we have to do. That option again is an option that you and me have to give to the patient. When we do that procedure, we obtain material which is then sent off to the lab, and that can be looked after by QFPCR or FISH for a rapid diagnosis of 13, 18, 21 and the sex chromosome aneuploidies. And then if you're thinking of Down syndrome, you do a conventional karyotype, which we almost don't do anymore. We do it only when we suspect a translocation. And a microarray is what we used to do until last year, and we have replaced it with a exome sequencing. We've always wondered why in Germany they do exome sequencing and not microarray. And then we realized that microarray was a test done in the lab, just like the ELISAs and the PCRs. But what we do is a sequencing of the gene, what we call a next generation sequencing, which is the true reliable way of looking for any genetic abnormality. Most of these invasive procedures are very safe, especially in experienced hands, and there would be a risk of about 1 in 1,000 by the time you've done your first 100 tests. But this is something you have to tell the patient always. And the patient who's had otherwise a chance of a miscarriage, like a septate uterus, or a patient who has had previous miscarriages or a fibroid, will have a slightly higher risk of a miscarriage because of an invasive procedure. Then we must also explain to them that these risks mean 1 in 800 does not mean that 1 out of 800 will have a miscarriage. That is of course true, but that one normal fetus would be miscarried for every 16 cases of trisomy that you diagnose of trisomy 21. So therefore, there is that risk of miscarriage which has to be explained to them. And please do remember that everywhere in the world, there are very few people who would opt directly for invasive testing because it is not possible for any government anywhere in the world. We will probably exceed all those expectations and offer it to everyone. But the fact is that we would still offer screening to everyone, not invasive procedures to everyone. What we look for in terms of the aneuploidies is not all of the genetic disorders. What we are truly looking for is the number of chromosomes that are there. If you have 3 trisomy 21s, that's called Down syndrome. You also have a variation where you have a translocation 21, where part of the 21 is transported onto another one, and therefore you have technically a trisomy 21. If we have 3 of the 18 chromosomes, that's Edwards syndrome, and you have trisomy 13, which is Patau syndrome. You have a missing sex chromosome in monosomy X. You have the triploid, which have 333 of each chromosome, as you see over here in the bottom right. And then you have, of course, a variable contribution of all of these in that little busy chart that you see at the bottom. But that is really what is the incidence. Now, out of these 3 common ones, the 21, 18, and 13, the 13 and the 18 are lethal, and therefore they don't have that bad a prognosis, because even if you were to miss them, we will lose them soon after birth, which is sad, but nevertheless. The good news is that they have so many structural abnormalities that we will almost always spot them on a 12-week scan. We learned early this morning that the ISWA guidelines, even the basic ones, will be able to identify the 13 and the 18 at 12 weeks plus. Not at 11 weeks plus, but at 12 weeks plus, and that is what we will follow. Then, therefore, for trisomy 21, we don't have so much of the structural stuff. For that, we then use a combination of what we call biomarkers. They are the maternal serum biochemistry, and then you have ultrasound markers, which is the thick nuchal translucency, the absent nasal bone, and of course, ductus venosus, reduced flow at the end of the cycle, and tricuspid regurgitation. Now, this concept I have already explained to you right in the beginning, that all these are non-specific. They occur in the normal population and in the abnormal population, and we put them together mathematically to give us a risk, which is what you learned in the panel discussion. Then we have a cutoff on these risks which guide us for further testing. When we look at all this biochemistry stuff, we realize that there are certain definite patterns of what happens. All 3 are associated with an increased NT, but the PAPE is low in trisomy 21 and the free beta HCG is high, and in trisomy 18 you have a low PAPE and a low free beta HCG. I also want to warn you about HCG, which is a biochemical parameter but is thermolabile. That means from the month of March all the way to the month of October, November, which is Holi Se Diwali, you will get much more high levels of free beta HCG. So when you transport these samples, we have to make sure that either we separate the serum and send it immediately at your center, which is not difficult, it only requires a centrifuge, but to make sure that these are then transported correctly. Otherwise, every test will come positive, and we in the fetal medicine field feel, ha, one more amnio, which is not correct. We have to only do amnios where they are needed, or we only have to do CVS where they are needed, and therefore we will make sure that our HCGs go in the correct way possible. We know that all these tests have evolved. Many, many years ago, when we started with the triple test, we thought it was the best thing that happened to mankind after maternal age, but it only had a 65% detection rate, and we threw it out of the window. The second trimester quadruple test came along with just about a 75%, and we say, okay, Then we realized that our detection rates in early pregnancy are better. So at 12 weeks, we started doing free beta HCG, PAP-A, and NT, and we reached a 96%. And then about 12 years ago, we started NIPT or cell-free DNA, and we reached a detection rate of 99.6%, which is really very, very good, and that is what should be doing. The question was that NIPT went house to house and said, come, give me your blood, I will come to your house, I will take it, and you will know that your baby is okay. No counseling, no nothing. Everybody presumed that the only disorder that ever takes place in their life is trisomy 21. We have to specifically tell them that, look, these tests that we're talking about for first trimester screening are for trisomy 21. That is what aneuploidy screening is all about. 13 and 18 you will now spot on ultrasound, you're happy. This whole story is about going and finding these trisomy 21s and giving the patients the option of destroying them. Please remember that there are people like me who will never destroy a pregnancy. And people say, what? You founded the Society of Fetal Medicine and you won't destroy a pregnancy? No. I will not, but my patients might want to. So we will, like I said before, give them that option. And if they don't want to destroy, then that is fine. But we will never ever do this whole story without doing an ultrasound first. Because NIPT works on the amount of fetal DNA. And if that is less than about 4% of the total DNA that is circulating, the NIPT is not so accurate. When we have free DNA in the mother's circulation, there is maternal DNA and there is fetal DNA. And the fetal DNA is actually a placental DNA. The heavier the mother and the younger the pregnancy, the less the fetal DNA and the more the maternal DNA. Therefore, we must do at least these at 12 weeks in pregnancy. And in a city like New Delhi, where our BMI has shifted from 16 to 29, we now get very stuck with having to do these at about 13 weeks. Because otherwise, all these people get an unequal result, and then we have to repeat it again after a few weeks, which is really anxiety inducing, and therefore we like to do it at the right time. Therefore, we have to do it, and therefore all these tests have appeared. So we also have to make sure whether it's twins or not, and if the baby is alive or not. And therefore, you must do a 12-week scan before we do an NIPT or before we do first trimester aneuploidy screening using PAP-A and free beta HCG. So moving on from that point, what do we have? We have second trimester testing, which is in the bottom part of this screen, which we avoid, but we need to do it sometimes when our patients report late. The rest of them, we realize that if we go by maternal age alone, we will only detect 30% because most women above the age of 35 don't produce so much, although more of them are now having babies at a later age. And therefore, the detection rate is not acceptable. If you use only the maternal characteristics and you use nuchal translucency, you will go beyond 75 and reach about 80-90%, but it may not be as good as you want, and therefore, ideally, you must combine it with biochemistry. The other thing is that if you were to use only biochemistry and not use an NT scan, you're going back to that second trimester triple marker again, and that is not justified. Therefore, we will never use maternal characteristics and only biochemistry. We must have a good NT. And of course, if on that wonderful NT scan, you combine everything, that means maternal characteristics, NT, free beta HCG and PAP-A, you will end up detecting about 95-96%. And if you were to add on nasal bone or tricuspid floor ductus venosus, our detection rate is 96%, and importantly, the false positive rate goes down to 2.5%. So ideally speaking, multiple ultrasound parameters plus PAP-A plus free beta HCG in what is called the combined test plus additional ultrasound biomarkers. What are these maternal characteristics? One of them is, of course, maternal age. The other is maternal weight. The ethnicity, whether she is of the really Eastern origins like Japan, China, Korea, and so on, whether they're South Asian or whether they're white or whether they're of African origin. Also the number of fetuses, diabetes, smoking, and some people add a few more. And then to this we add on nuchal translucency, nasal bone, ductus venosus, and tricuspid regurgitation. We've dropped a few of these as we go along. We also know that we no longer use just a single figure for nuchal translucency like we used to in the good old days. And what we do is, we actually relate it to gestational age. And we look to see whether it is more than the 99th centile. And then we say, okay, this is what we need to look at. Previously, we were using 3.5 as a cutoff, which is not bad, but we will come to that in a while. But what we've also realized is that there is a certain number of babies with a nuchal translucency between the 95th centile and the 99th centile that you and me should be running after, because a very significant number of babies with Down syndrome have a nuchal translucency between the 95th and the 99th centile. And therefore, for those also we must think of alternatives, and what I usually end up in those situations is to offer them an NIPT. I may not feel strong enough to offer them invasive. I offer invasive to everyone because that is a good choice. But although we're not supposed to be directive in our counseling, you know how to emphasize, you know how to talk to people. And I would push them more for non-invasive if they were between the 95th and the 99th. So therefore we would pick up those. Once you have all of this worked out, you go into one of these nice algorithms and you calculate the actual centile, and you can do it free of cost on the FMF software if you have passed the tests, or completely free of cost on perinatology.com. And then you get your actual level. But really what you and me have to remember is that a significant number of babies with a thick NT will be normal, and therefore we should never terminate a pregnancy on the basis of this factor alone. Never, never, ever. We must also realize that it is not necessary that every Down syndrome baby will have thick NT plus abnormal biochemistry. They might have completely normal ultrasound morphology and have abnormal biochemistry. So we must encourage biochemistry for everyone, therefore the combined tests. And we also learned this morning that our ultrasound should be done a little later to pick up the anomalies, and therefore we do it rather at 12 weeks, 4 days. So typically when I date a pregnancy, when they come to me between 7 and 10 weeks, I give them an appointment for 12 weeks, 4 days. If I'm on holiday or I'm in Patna, then I call them back at 13 weeks, 2 days, but not at 11 weeks, 5 days, because then we tend to miss the structural abnormalities. Then after this is something which is very tricky, but which you and me must understand. And that is this, that different people use different cutoffs. And different people from different parts of the country use different cutoffs, and different people in different parts of the world use different cutoffs. I like to follow Kypros Nikolaidis' method, where he says that, look, you get a risk of greater than 1 in 10, don't even discuss very much else, and say, look, if you want to find out about Down syndrome, go ahead with invasive testing. If I have a figure of 1 in 10 to 1 in 50, I sort of say, well, you have these two possibilities. The NIPT might take 10 to 14 days to come, and if it's positive, then I might still need to do an invasive testing, so you decide. Or I might get a no call, then I might have to repeat it, another 2 weeks will go by, you decide. But it is always the patient who decides. So I will sit like a waiter at Pizza Hut. Yes, ma'am, I have this burger, that burger, this burger, that burger, plus I have 19 pizzas to choose from. Which would you like? No, what would you do in your case? Hello, I'm not pregnant, how would I decide this? नहीं नहीं दादू तो ये अब आप क्या करेंगे? हम क्या बताएं, सबके दादू थोड़े ना है. So you have to make them realize that they're intelligent people, and the more we educate people, the more they will take these options. If we continue to treat them like animals of no brain, which is never true, animals are very intelligent people, we will be able to train them correctly, and we will teach them to think that they are responsible for their own reproductive decisions. Just like we should teach them about the difference between a copper T and a condom. The correct way of contraception is a condom, because it covers a damn male who's filthy. Yes, everybody knows that. And yet we say copper T, postpartum copper T. It doesn't help, because that woman is going to die of infections otherwise. So we have to encourage them to make their own sensible reproductive decisions. And then the market has all of this available, and this is the most important chart. So for all of those wonderful postgraduates, take out your telephones and take a good picture and study this every night after you finish your night prayers. Because this is what is going to let you know how to use and which test to use. So age is not recommended. crown rump length plus NIPT is really ideal, but it will not tell you anything about the risk for preeclampsia. Not acceptable. The next thing is that age and biochemistry have a poor detection rate, not acceptable. And the one test that we use all over the world, irrespective of rich man, poor man, if you're not privately paying for it, is age plus crown rump length plus maternal factors plus NT plus PAPE plus HCG, which is called the combined test. Today we combine PLGF with it because the incidence of Down syndrome is 1 in 800 pregnancies. The incidence of preeclampsia in Bihar in published data is 1 in 27 pregnancies. If you take the new definition of preeclampsia, the incidence in published data from South Bihar is 1 in 27 pregnancies. That is a lot, which is why we offer the 3,000 rupees, and both those companies are offering it, and please, please, please do take advantage. We now also have this combination of the first trimester and second trimester screening, where we're not supposed to tell the patient the results, but our patients die of anxiety, and so we don't use this option ever. We have some new tests, and one of them is called the first trimester quadruple, where we've added, in addition to PLGF, alpha-fetoprotein. This test was added by a company which presumed that all people who do ultrasounds in this country are stupid and not capable of discovering any neural tube defects, and they needed to be poked into believing to look for anatomy at 12 weeks. This is not true. So very rapidly we went on, and the same company produced a PENTA test. And this PENTA test added on dimeric inhibin A. And the detection rate for the first trimester PENTA test is 98.5%, with a false positive rate of only 1.2%. So really speaking, if you want that difference between a 5,000 rupee test and an 8,000 rupee NIPT, this is how we should be following it up. And therefore that is what we should be doing. We will also remember that for all these patients, if you find a structural abnormality, that's good, but otherwise, NT does not mean only Down syndrome. NT very, very much means other possibilities such as cardiovascular defects, mediastinal lesions, skeletal dysplasias, neurodefects, congenital infections, and so on, and therefore we do need to see that. If you find, of course, something structural, like you've been seeing during the day, a lobar holoprosin carefully with the proboscis, you will not even waste your time in trying to figure out whether you're going to do invasive testing or not. You will go right ahead and do invasive testing. And please do remember that we must really do a transvaginal scan, like you heard this morning, that you will do that transvaginal scan and follow it up accordingly for anatomy. And therefore there are things like anterior abdominal wall defects, megacystis, and so on, where you will like to follow these up. And if you discover a very severe asymmetric growth restriction, where you have an almost normal-sized head and terribly small abdominal circumference, start thinking in terms of triploidy. And that will get you past the first trimester. Then there is also the second trimester business, where you and me have to be aware. Because what do our patients do? Fifth month ho gaya chalte hain. Because that's what they've been doing for generations. It's not their fault. So until you and me educate them, we will find patients who come later. What I offer them is always NIPT at that time. And if they don't do it, then we take them through this genetic sonogram, where you've heard from Dr. Krishna Gopal today that we add up what is present, what is not present. If there is ventriculomegaly, of course we will always do a invasive testing. For the rest, we give them option of NIPT versus everything else. For everything that is present, we reduce the risk, we increase the risk, and everything that is not present, the risk becomes less, and therefore that's how we're going to be doing it. Please remember that everywhere, and I'll only take 2 minutes more, we have the option of what we call institutional protocols. These protocols that we talk about represent minimum practice guidelines, but for you and me who work with 100 patients, one machine, half a person who's doing imaging, and everybody else jumping in and out of the room, it's not always possible. We must be honest with our patients and say that currently Bharat Sarkar is not paying us for this, and this is not good, and you please go and get it done where you think it is good. Because here we only have a detection rate of 45%, and you can go outside into the world and decide what you want to do. Why can't you give it? Hey, that's not my problem. Don't vote for them next time. Very simple. I mean, there are elections coming, and I won't get into the politics of it. Unfortunately, all the parties are good friends of mine and patients, but that's the story. Yes, the efforts are on, and like I said, at the Ministry of Health, we're going to actually make sure that we privatize maternal and child health, and everybody will get the best deal then for sure, but you and me will have to drive that. Meanwhile, for the patients who can afford it, offer them the whole palette of sensitivities and costs and let them decide. The basic minimum must include the combined test. Because of the high incidence of preeclampsia, we need to add PLGF and counseling pre-test, counseling post-test, and counseling works. Remember that what I've told you about this 3,000 is a community payment program where every patient is paying just a wee bit more, 100 or 200 rupees more, included in the 3,000, and they can get that free NIPT, and the positive NIPTs can get a free amnio QFPCR. So that is how we will work for now, and thank you so much for your attention.
Dr. Khurana. Thank you, Dr. Khurana, for such a detailed description of all these aneuploidies, going over the weeks of pregnancies and telling us about the future also, and how fast everything is developing. First we do the biochemical, then go to genetics, then biochemical, then again back to non-invasive, and something else might be coming sooner or later, and then
Yes.
we get 100% detection.
Yes, I'm
Could
hoping
be.
we have a saliva test for trisomy 21. Yes.
So anybody, it's open for questions. Anybody having any questions? So thank you so much
Thank
for
you.
your brilliant talk. Thank you.
Thank you indeed.
Everyone, please don't leave. We still have the quiz. It's going to be an interesting quiz. Okay, jo ja rahe ho.
I would request Dr. Anita Singh ma'am to please come on the stage to felicitate our chairpersons of this session.
Aishwarya, Dr. Savita Rungta ma'am. Dr. Kumkum Sinha ma'am. Dr. Alka Pandey ma'am. And Dr. Shipra Roy ma'am. Ma'am, I also request you to kindly felicitate Neelam Sharma ma'am. She's coming on stage. Because she's leaving.
Now we are on for the next interesting session, which is the quiz by Dr. Rakhi.
No problem, ma'am. So quickly, can you please open kahoot.it on your Kahoot, KAHOOT.IT. Please type kahoot.it. 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 And So just go to kahoot.it. It will ask for a game pin which is being generated. kahoot.it, and the game pin is 87567.
Are you all able to open it? Anybody has a doubt, then can please raise their hands.
If anyone has a doubt, they can go to the app, but it can be easily done to the kahoot.it. Pin ID is 87567. It is displayed on the top. 87567. Eight seven 87567. If anyone has still not joined, let me know, otherwise I'll start soon. So I have 41 people. $42. Anyone still remaining? Anyone needs help? Ashita. Ma'am, phone on करके Google open कीजिए. करिए ना मैम, please ma'am. Please ma'am, it would be fun. And it's easy. Shanti ma'am. Ma'am का help करो ना. Open. Ma'am, you give it to her. आशिता, अनीता मैम का भी कर दो. पूजा, हेल्प करो ना मैम. आपको हेल्प चाहिए मैम? हो गया. Kahoot.it. आपका हुआ सर? Okay, thank you. Kahoot, K-A-H-O-O-T, Kahoot.it. 87567. IT. Vijay Lakshmi ma'am is not doing. Okay. Anyone needs help still? Who? You don't join, okay? 87567. Ma'am, it is displayed on the screen. 87567. Game pin, yes. 567. ये इसमें ये में अच्छा साउंड डिस्प्ले होगा ना हाँ साउंड कनेक्टेड है ना ठीक है ओके 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 आई एम वेटिंग क्या कर रहे हैं अच्छा ठीक है ये किसमें स्पीकर किसमें कर रहे हैं आप ये Oh, great. We have 56 players as of now. Who has not joined? Anyone still needs help? Okay. Start. Everyone okay? Okay, ma'am. So, quickly I'll tell the instructions. So read the questions have to be understood carefully. First two are dummies, so there are no marks. There's limited time for the answers, 20 to 30 seconds, and faster answer will give you more marks. You cannot change the answer after you have touched one option. Okay, so choose carefully. Yeah, it's okay. I'm still in the dummy questions. Ma'am, ये dummy है ma'am, dummy. Just to get an idea, feel of the quiz. So who is the Chief Minister of Bihar? Narendra Modi, Nitish Kumar, Lalu Yadav, Amit Shah. फोन क्या नहीं आ रहा है आपका? दरबार हॉल का Okay, so This is also a dummy question. What is the full form of SFM? SFM is our patron society. So is it Society of Fetal Medicine, Special Fetal Medicine, Social Fusion Media, and Special Forensic Medicine? This is also a dummy question. No marks for this. What is not coming? Please see Nashita. ऑप्शन नहीं, ऑप्शंस इधर हैं प्लीज. आपको वो सिंबल्स को फॉलो करना है. ट्रायंगल है, रोम्बॉइड है, सर्कल एंड द स्क्वायर. So now the started. Echogenic bowel, all are true except it is a soft marker. So what is wrong? It is a soft marker for trisomy 21, may be seen in cystic fibrosis. Normal bowel echogenicity is more than bone, may also be seen in intrauterine infections. All are true except echogenic bowel. Soft marker for trisomy 21 may be seen in cystic fibrosis. Normal echogenicity is more than bone and may also be seen in time up. So the correct answer was that normal bowel echogenicity is less than bone actually. Okay, rest all is correct. And A and D is on top. So next question is a true or false. Echogenic focus in heart is a low risk soft marker for trisomy 21. Is it true or false? So some of the soft markers have high risk and some of other low risk. So is it, so this is a low risk soft marker as I say. So is it true or false? Is it a low risk soft marker or a high risk soft marker? So echogenic focus in heart is a low risk soft marker and the correct answer was yes, it is a low risk soft marker. It is a soft marker but a low risk soft marker, unlike say nuchal fold thickness, which is a high risk marker. So Dr. Prachi is on top. Next question, which of these findings is seen in this image? Of the mentioned findings, are we seeing retrognathia? So this is our image. Are we seeing retrognathia, binder's facies, frontal bossing or sloping forehead? This is a mid-sagittal view of the fetal face profile. And are we seeing a retrognathia, depressed chin, a binder's facies or a flat face, frontal bossing where the frontal bone is prominent, or a sloping forehead as seen in microcephaly? So time is up and the correct answers were retrognathia. The chin was depressed very much. So now we have Manik on top. Next is again a true or false question. Mild ventriculomegaly is lateral ventricular diameter of 8 to 10 mm. We had this in the panel discussion, so I hope everyone gets this correct. Mild ventriculomegaly is lateral ventricular diameter of 8 to 10 mm. Is it true or false? Mild ventriculomegaly is lateral ventricular diameter of 8 to 10 mm. It is false. The true, only when it's more than 10 mm, we call it mild ventriculomegaly, 10 to 12. So this time again, Manik is on top. Next question, what is shown in this image? What is being shown in this image? So here I have displayed this part of the heart in grayscale and in color. Is it LVOT, left ventricular outflow tract, or is it RVOT, the right ventricular outflow tract? LVOT, left ventricular outflow tract, or see this in grayscale, I had shown it in my TOF case. So is it RVOT or is it LVOT? LVOT, left ventricular outflow tract, gives out aorta. So correct answer was LVOT. And who is Manik? Who is Manik? Okay, so next question. This image rules out which of these conditions? Which of these conditions you would say is not there in this patient after seeing this image, which is showing these things? Is it tetralogy of Fallot TOF? Is it total anomalous pulmonary venous drainage TAPVC? Or ventricular septal defect VSD? Or common arterial trunk CAT? Which of these conditions will be ruled out if you can get this image on your ultrasound. So the correct answer was TAPVC. Those were the pulmonary veins. We see them drain into the heart. So you can rule out that it will not be total anomalous pulmonary venous drainage. Manik has come down. Tariq is on top now. And next question. In the absence of the marked structure, all of these form DD except if this structure is absent, which all of this will be DD except it may be normal, it may be trisomy 21, it may be Binder's facies, or it may be other aneuploidies. Which one is wrong? In the absence of this marked structure, all of this will form the differential diagnosis, except that the baby is normal, having trisomy 21, having Binders or other aneuploidies. No loud answers, please. So the correct answer was Binder's facies. No, absent nasal bone may be seen in normal babies, trisomy 21 and other aneuploidies. So Dr. Richa is on top. Okay, and what is the most likely diagnosis in this given image? This also has been displayed today. So this is the LV, this is the right ventricle, left atrium, right atrium. Is it hyperplastic left heart syndrome, tricuspid atresia, tetralogy of Fallot, or cardiac rhabdomyoma? So is it hypoplastic left heart? Is it tricuspid atresia, tetralogy of Fallot, or cardiac rhabdomyoma? I gave a lot of time for this question, but I think already I have gotten all the answers. Is it hypoplastic left heart, tricuspid atresia, tetralogy of Fallot, or cardiac rhabdomyoma? Okay, so now to the next question. The correct answer was hypoplastic left heart. Dr. Ruchi had shown this case and maybe the same image. So Dr. Richa is still on top. Next question is, what is the marked structure? There's something that I have marked here. This structure. What is this structure? Is it the NT, nuchal translucency? Is it the brainstem? Is it the intracranial translucency or fourth ventricle? Or is it the aqueduct of Sylvius? So this structure, this hypoechoic black structure, what is this? Is it nuchal translucency, brainstem, IT, or aqueduct of Sylvius? So the correct answer was brainstem. That this was a typical NT image that we do in our NT scanning. Dr. Richa is on still the top. And next question, what is difficult to diagnose but relatively easy to manage? Is it early FGR stage 1, early FGR stage 2, early FGR stage 3, or late FGR? But you can diagnose, is difficult to diagnose but relatively easy to manage. What is difficult to diagnose? So it's tricky to diagnose this condition, but relatively easy to manage this condition. Is it early FGR stage 1, stage 2, stage 3, or is it late FGR? So the correct answer was late FGR, making the diagnosis is difficult, but you just have to deliver the baby to treat it. Dr. Richa is still on top. And this is a true or false question. So small 28 weeks baby with reversed end diastolic flow in umbilical artery is stage 3 early FGR. Is this true or is this false? If you can see a small baby, FGR baby, 28 weeker with reversed end diastolic flow in the umbilical artery, is it it's stage 3 early FGR? Is it true or false? Small 28-week baby, reversed end diastolic flow in umbilical artery is stage 3 early FGR. So the correct answer is true. It is indeed stage 3 early FGR. Mrin. Who's Mrin? Minalini is on top. Okay, so next, what is the finding in the image? So this is the image, a very typical image. Is it a flat face binder's facies, a depressed chin retrognathia, a frog-like face anencephaly, or premaxillary protrusion in cleft lip and palate? So is it a flat face binders, depressed chin retrognathia, frog-like face anencephaly, or premaxillary protrusion, cleft lip and palate? So this was typical of anencephaly with a frog-like face with prominent eyes and no head. So Mrinalini is still on top. Mrinalini, I should have asked you not to sign up for this. What is the finding in this image? This is a cross-section image of the abdomen. Is it showing a normal stomach? Is it showing double bubble sign? Is it showing absent stomach bubble or dilated bowel loops? What is seen in this image? Does it show a normal stomach? Does it show a double bubble sign? Does it show an absent stomach bubble? Or does it show dilated bowel loops? This is a cross section of the abdomen for measuring the AC. So this was indeed a normal stomach with nothing, a normal good stomach seen. This had come to me a reference for double bubble sign and megacystis. Then it was a completely normal. So whenever you see a patient, a report comes to you with very gross abnormalities, always, as you must all be knowing, it's very important to do a second opinion for medical legal purposes. And sometimes the first person's diagnosis may not be, may be mistaken or incorrect. Mrinalini still on top. What is the observation about nasal bone in this image? So this is an image showing this is the front of the nose seen there. So is it nasal bone is present and normal? I hope everyone can see it clearly. Is it present but looks hypoplastic? Is it absent, or we don't need to assess the nasal bone? So what is the observation about nasal bone in this image? Do you feel it's present and it's good? Do you feel it's present but it's hypoplastic? Do you feel it's absent? Or you don't need to assess it? It was an absent nasal bone. So we were seeing two lines there. One was the nasal skin and nasal tip, but the line of the nasal bone was missing. Often this image is reported as normal nasal bone, very commonly. Mrinalini is still on top. So cranial finding in this 8 weeks fetus sagittal section. This is a transvaginal section. It is an 8-weeker, 7 weeks, 6 days to be exact. This is the crown side, this is the rump side. So what are you seeing in the cranium of this 8 weeks fetus? Is it hydrocephalus? Are you seeing normal brain vesicles? Are you seeing a posterior fossa cyst? Or is it an anencephaly? Do you think this is hydrocephalus? Do you think these are normal brain vesicles? Do you think this is a posterior fossa cyst or a case of anencephaly? These was indeed normal brain vesicles. Sometimes I do get reports where they mention that there are some cystic abnormal structures seen in this early fetus. So you should get used to what is the normal appearance of this small baby. With the better machines, you see better. Okay, so what is the finding in this image? I think this is my last question. So this is a cross-section of the heart. This is the right ventricle, this is the left ventricle, and this is the interventricular septum. Are you seeing a ventricular septal defect, VSD, AVSD, atrioventricular septal defect? Are you seeing ASD, atrial septal defect, or is it looking normal? This is the right ventricle, the left ventricle, the interventricular septum. So is it a VSD, an AVSD, an ASD, or is it looking normal? So the correct answer was VSD. It was a ventricular septal defect. And quickly poll, how would you rate today's CME? Was it excellent, good, okay, or below average? We are done. We are done. A few people have otherwise rated us, I would say. Thank you for your ratings. So, thank you very much. And now we'll get the winners. Sound nahi aaya. Itna acha music basta hai. Ruchika is on number 3. Ruchika, who's Ruchika? Okay, so Ruchika. Dr. Shashi is number 2. And Dr. Mrinalini is on top. So let's clap for the winners.
I would now request Dr. Ashok Khurana sir to please come on the stage to felicitate our esteemed obstetricians and gynecologists who have taken the time to be here for the whole day. First, I would request sir to please felicitate Dr. Vijay Lakshmi Mittal ma'am. Dr. Vijay Lakshmi Mittal ma'am, please come on the stage. Next, I would request Dr. Anita ma'am to please come on the stage. Dr. Now I would request Dr. Shanti Roy ma'am to please felicitate sir. I would request Dr. Krishnan Gopal sir to please come on the stage. And ma'am will please felicitate Dr. Krishnan Gopal. Thank you everyone for this overwhelming response and making this dream come true. All the seniors, all the colleagues and the technical team also who made it possible to finish on time. Now I would request Dr. Anand Abhishek to please announce the winners.
Yeah, thank you very much, and thank you very much for the overwhelming response. And I'd like to call upon the participants plus who won the paper and the poster. They really deserve a clapping as well as some appreciation as well. So I'd like to first announce the winners of the paper presentation. So the third prize goes to V. Ruchika. Is she present? Can she come on the stage? The title of her paper was Fetal Megacystis. So we need a big clap for her. The second prize for the poster paper presentation goes to Dr. Bhumika. Her paper was Associated Osteogenesis Imperfecta. The first prize goes to Dr. Richa Jha. A big clap for her. The topic for paper was FTLT plus PIGF ratio for prediction of the preeclampsia in the late second trimester. Now we have the for the e-poster as well. So can we have Dr. Shadya and Dr. Jyotsna? Are they present here? Yeah. For the third prize. Can we have a big clapping for them? The second prize for the e-poster goes to Priyam Sharma. The paper was on meconium pseudocyst. And for the first prize, Dr. Shashi Bala. A well-deserved clap for her. For the first trimester uterine artery PI values. Raki? Quiz? Popular? Third. We have some prizes for the quiz as well. So third was Ruchika. Again. Toffee दे दूँ? Second कौन था? Second was Dr. Shashi Bala. She can get two also. The first prize goes to Dr. Mrinalini. Well played. Can we have a huge round of applause, please? First prize, Dr. Mrinalini. And thank you all for coming. And if we had made any mistakes, please pardon us. This was our first time for organizing such a great academic CME. Thank you everyone. Ma'am, you came, that's our biggest prize, ma'am.